Presiden untuk Indonesia Emas 2045 di bidang olahraga, yaitu Indonesia harus masuk 5 besar peraih medali Olimpiade. Itu target yang sangat ambisius, mengingat sekarang kita 50 besar, bukan 5 besar. Namun KONI cukup optimis, tapi mengharapkan banyak dukungan-dukungan dari UGM, dan mereka sangat percaya dengan UGM karena menurut mereka UGM punya senjatanya. UGM terdepan untuk pengembangan sport nutrition, untuk gizi kesehatan. Salah satu unggulan yang dikembangkan oleh teman-teman di gizi kesehatan selama 2 dasawarsa perjalanan prodi gizi kesehatan. Dan masih banyak lagi capaian-capaian pengembangan-pengembangan di gizi kesehatan kita sejak berdirinya prodi gizi kesehatan ini, nutrigenomik, gizi kerja, gizi bencana, dan sebagainya, termasuk INHESION ini. INHESION ini kalau tidak salah sudah ke-7 kalinya ya, kalau tidak salah. Jadi sudah secara rutin, annually organized every year. Dan ini merupakan salah satu platform atau forum yang cukup bergengsi di bidang gizi kesehatan. Kami sangat bangga dengan program unggulan dari Himagika ini. Dan masih banyak lagi capaian-capaian yang bisa dibanggakan dari prodi gizi kesehatan selama 2 dasawarsa ini. Para alumni yang nanti akan hadir juga di temu alumni adalah saksi perjalanan sejarah penuh prestasi dan dedikasi dari prodi ini, sekaligus bukti nyata keberhasilan pendidikan prodi gizi. Untuk itu, atas nama fakultas, saya ingin memberikan apresiasi yang setinggi-tingginya kepada semua pihak yang telah mendukung perjalanan 2 dasawarsa prodi gizi kesehatan, dan juga kepada segenap panitia INHESION yang setelah 7 tahun berturut-turut rutin menyelenggarakan ini. Terima kasih pada para pengelola departemen, prodi, para dosen, tendik, mahasiswa, alumni, dan semua yang telah berkontribusi dalam membangun fondasi kemajuan prodi gizi kesehatan. Harapan kita bersama, prodi gizi kesehatan ke depan semakin maju dan semakin berkontribusi dalam pembangunan kesehatan bangsa. Saya ralat, tidak cukup hanya berharap, mari kita kuatkan tekad untuk melanjutkan perjalanan dasawarsa-dasawarsa berikutnya dengan semangat yang tinggi untuk terus mengembangkan gizi kesehatan demi kemajuan bangsa. Sawah hijau ditanam padi, awan putih menghias angkasa. Maju terus prodi gizi demi cita nusa dan bangsa. Terima kasih, selamat merayakan 2 dasawarsa prodi kesehatan, selamat berdiskusi. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Yodi Mahendra Datta, for your inspiring words. Ladies and gentlemen, we gather here today at a momentous juncture to honor a journey of dedication, growth, and excellence. We are on the cusp of commemorating a remarkable milestone, the 2 decades anniversary of the establishment of the Department of Nutrition and Health. This commemoration marks a journey that began with vision, perseverance, and a commitment to advancing the field of nutrition and health. Without further ado, I invite you together for this commemorative event that pays homage to the dedication, achievements, and aspirations that define the Department of Nutrition and Health program's 20 years journey. Allow me to introduce to you someone who will be stepping into the role with grace and enthusiasm. I am pleased to hand over the MC duties to Ms. Umi Salamah, Master of Humanities, who will be your host for the celebration event. Please welcome Ms. Umi.
Thank you, Sabrina. I'd like to guide this session in Bahasa Indonesia, not in English. Saya takut kebanting dengan Gen Z. Selamat pagi, Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh. Yang belakang belum ada suaranya.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih Prof. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan. Yang sangat kami hormati yang sudah bergabung bersama kami melalui Zoom, Founding Father Gizi Kesehatan Profesor Dr. Hamam Hadi, MS, S.Pg.K, S.Gz, yang kami hormati.
Assalamualaikum.
Waalaikumsalam warahmatullahi. Sudah bisa bergabung bersama kami ya, Prof?
Sudah.
Baik, baik. Silakan Pak Dekan. Baik, kami ulangi kembali. Yang sangat kami hormati, Founding Father kami yang sudah bergabung bersama kita semua melalui Zoom, Profesor Dr. Hamam Hadi, MS, S.Pg.K, S.Gz. Yang kami hormati, Dekan FK-KMK UGM, Dr. Yodi Mahendra Data, M.Sc, Ph.D, FR.SPH, Wakil Dekan Bidang Kerjasama, Alumni dan Pengabdian Masyarakat, Dr. Sudadi, SPAN Konsultan, seluruh dosen dan staf kependidikan Departemen Gizi Kesehatan FK-KMK UGM, seluruh tamu undangan dari jejaring rumah sakit, puskesmas dan catering, keluarga alumni Gizi Kesehatan atau KGK, dan seluruh peserta International Symposium INHESION 2023. Izinkan kami untuk mengambil alih forum ini sejenak untuk memandu sesi seremonial 2 dasawarsa Prodi Gizi Kesehatan FK-KMK UGM. Bulan Agustus adalah bulan istimewa bagi Prodi Gizi Kesehatan. Selain karena bulan kelahiran Republik Indonesia dan juga kelahiran beberapa orang penting di gizi kesehatan, termasuk yang sudah bergabung bersama kita melalui Zoom, tetapi juga bulan ini adalah bulan kelahiran Prodi Gizi Kesehatan. Dan tahun ini Prodi Gizi Kesehatan telah berusia 20 tahun. Saya boleh minta tepuk tangannya? Kami mengundang Bapak Ibu sekalian pada hari ini karena kami ingin membagi kebahagiaan dan rasa syukur kami kepada Bapak Ibu. Kami juga ingin menyampaikan terima kasih kami kepada Bapak Ibu atas seluruh dedikasi dan kontribusi Bapak Ibu sekalian selama perjalanan 20 tahun Prodi Gizi Kesehatan FK-KMK UGM. Dan lebih jauh lagi kami ingin membagi momentum-momentum indah kami selama 20 tahun perjalanan ini kepada Bapak Ibu. Oleh karena itu kami mengundang Ketua Departemen Gizi Kesehatan FK-KMK UGM untuk memberikan sambutan sekaligus berbagi cerita indah perjalanan kita selama 20 tahun perjalanan kami. Disilakan kepada Dr. Susetyawati DCN M.Kes.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera bagi kita semua. Yang kami hormati Bapak kita, Bapak Gizi kita, Founding Father Gizi Kesehatan, Profesor Dr. Hamam Hadi, M.Sc, S.Pg.K, Science Doctor, Bapak Dekan FK-KMK UGM, Dr. Yodi Mahendra Data, M.Sc, Ph.D, beserta Wakil Dekan Bidang Kerjasama, para narasumber INHESION 2023, seluruh tamu undangan, jejaring, lahan rumah sakit, puskesmas, dan catering, dan tentunya yang kami banggakan para alumni yang diwadai oleh KGK, keluarga alumni gizi kesehatan, dan seluruh peserta internasional Symposium INHESION 2023. Alhamdulillah pada pagi hari ini kita bisa berkumpul di ruangan ini dalam kondisi sehat. Seperti tadi disampaikan oleh pembawa acara, izinkan saya mewakili para dosen, tenaga kependidikan yang ada di Departemen Gizi Kesehatan akan menyampaikan terkait perjalanan sejarah dari Prodi Gizi Kesehatan 20 tahun ini. Mohon dibantu slide-nya. Baik, Bapak Ibu sekalian, sudah tidak terasa ternyata perjalanan dari khususnya Prodi S1 Gizi sudah berusia 20 tahun, sejak tahun 2003 sampai tahun 2023 ini. Ya, slide. Ya, sejarah perkembangan dari gizi kesehatan dimulai di tahun 1998. Terima kasih Prof. Hamam. Ini sudah ada foto-fotonya beliau. Ya, pada tahun 1998 sudah berdiri minat gizi kesehatan S2 di Prodi S2 IKM, bagian gizi IKM. Kemudian di tahun 2000 kita merintis program studi diploma 4 gizi dan alhamdulillah berjalan selama 3 tahun dari tahun 2000 sampai tahun 2022. Ya, slide. Ya, alhamdulillah kembali pada tahun 2003 Prodi S1 Gizi Kesehatan ini merupakan prodi pertama di Indonesia. Tepuk tangan untuk kita semua. Ini sudah banyak alumninya, ini yang ada di sini, ada Pak Fahmi. Dan atas kerja keras dari Prof. Hamam yang pada waktu itu sebagai Kaprodi dan juga sebagai Ketua Asosiasi Institusi Pendidikan Gizi Indonesia, bersama dengan, mungkin gambarnya kecil ya, di sini ada Prof. Kirman selaku Ketua Kolegium Ilmu Gizi Indonesia, dan juga ada Pak Arum selaku Ketua Persatuan Ahli Gizi Indonesia merintis untuk membuka prodi profesi dietitian, dan alhamdulillah UGM merupakan prodi profesi dietitian yang pertama di Indonesia. Ya, berhubung satu dengan lain hal sehingga kita membuka untuk prodi profesi dietitian dalam waktu 3 tahun, tetapi alhamdulillah pada tahun 2019 kita bisa membuka kembali prodi profesi dietitian. Berikut adalah lulusan pertama yang dilantik. Di sini ada Bu Mirza nampaknya sebagai alumni yang pertama. Ya, slide. Ya, diikuti dengan tahun-tahun berikutnya ada pelepasan mahasiswa-mahasiswa S1 Gizi, kemudian pelantikan dietitian yang sudah kita jalani selama beberapa tahun. Ya, slide. Dan sampai tahun bulan Agustus wisuda terakhir tahun 2023 dan dibuka tahun 2003, kita telah meluluskan 1.225 sarjana gizi. Dan kita juga konsisten bahwa kita selalu menerima mahasiswa tidak berlebihan, jadi hanya sekitar 100 mahasiswa untuk setiap angkatannya. Ya, slide. Untuk alumni dari program studi profesi dietitian, kita bisa lihat di sini bahwa pada periode profesi tahun 2007 sampai 2010 kita sudah meluluskan 110 dietitian, dan sejak tahun 2019 sampai terakhir kita pelepasan di bulan Februari tahun 2023 kita sudah meluluskan 74 dietitian. Ya, slide. Nah, Bapak Ibu sekalian, ini adalah profil-profil lulusan kita. Apakah ada yang hadir di Zoom? Nanti di sini ya, kita lihat di sini adalah lulusan-lulusan kita yang sudah berkontribusi bekerja di kementerian, baik itu di Kementerian Kesehatan, di BPOM, Kementerian Pemuda Olahraga, Badan Narkotika Nasional, dan banyak lagi alumni kita yang sudah mengabdikan kepada negara dengan bekerja di kementerian. Ya, slide. Slide berikutnya. Ya, sebaran lulusan kita juga sudah banyak yang bekerja sebagai praktisi kesehatan, yaitu di rumah sakit maupun di puskesmas. Kita bisa lihat di sini cukup banyak yang bekerja di wilayah Yogyakarta sampai di Jakarta, ada juga yang di RSCM, di Hasan Sadikin, dan banyak juga di rumah sakit yang tersebar di seluruh Indonesia. Slide. Ya, Bapak Ibu sekalian, perlu kami sampaikan bahwa sejak Prodi S1 Gizi buka pada tahun 2003 dan sampai tahun 2023 ini, Prodi S1 Gizi itu sudah mencapai lebih dari 150 prodi yang ada di Indonesia. Dan alhamdulillah alumni kita juga sudah banyak berkontribusi menjadi dosen, baik itu di perguruan tinggi negeri maupun di perguruan tinggi swasta, khususnya di Prodi S1 Gizi. Ya, slide. Nah, ini adalah profil-profil lulusan kita yang bekerja di industri, wirausaha, dan organisasi-organisasi lain. Misalnya ada di Kalbe, Aerofoods, kemudian Mayora, dan banyak juga alumni kita yang mengembangkan untuk catering ya, seperti di Live Diet Catering, Bima Sena Catering, dan juga di UNICEF, Dompet Duafa, dan lain sebagainya. Ya, slide. Alhamdulillah alumni kita juga banyak yang sudah melanjutkan studi lanjut, baik itu di S2 maupun di S3 dengan sumber-sumber pendanaan, baik itu dari dalam maupun dari luar negeri. Kita bisa lihat di sini alumni kita yang mendapatkan pembiayaan dari Fulbright, USAID, dan lain sebagainya. Ya, slide. Berikut adalah prestasi-prestasi mahasiswa baik yang di dalam maupun di luar negeri. Ayo adik-adik semua semangat ya, bagaimana memberikan kontribusi yang lebih baik lagi untuk prodi gizi dengan menorehkan prestasi seperti yang sudah dilakukan oleh kakak-kakak kelas ya. Kita lihat di sini cukup banyak prestasi yang sudah dicapai oleh mahasiswa. Ya, slide. Ya, slide. Ya, slide. Alhamdulillah kita juga sudah mempunyai keluarga alumni gizi kesehatan KGK, di mana KGK banyak sekali kegiatan yang sudah dilakukan bekerja sama dengan Departemen Gizi Kesehatan, baik itu dalam bentuk seminar, dalam bentuk mentoring, dan lain sebagainya, di mana ini semua tentunya untuk mendukung Tridharma perguruan tinggi. Ya, slide. Bapak Ibu sekalian, pada awal pendirian dari Departemen Gizi pada waktu itu masih di bawah IKM untuk S2, kita bisa melihat stafnya masih sangat terbatas. Bapak Ibu dosen bisa nostalgia gitu ya dengan melihat Pak Toto itu terlihat di depan ya. Ya, ini staf yang masih sangat terbatas ya, slide. Ya, di tahun 2023 ini alhamdulillah kita sudah mempunyai 28 dosen ya. Dan dari 28 dosen ini 50% sudah dengan pendidikan S3, dan sekarang ada 5 dosen kita yang juga sedang studi lanjut S3 dan juga didukung dengan Bapak Ibu tenaga kependidikan. Dan ini terakhir foto pada waktu kita raker terakhir ya tahun 2023 di Semarang dengan pasukan yang lebih banyak lagi sekarang. Ya, slide. Kerjasama yang sudah dilakukan sudah demikian banyak, baik itu kerjasama yang ada di dalam negeri yang sudah kita bina selama ini. Ya, slide. Ya, juga kerjasama yang sudah dicapai di luar negeri, tentunya dengan capaian-capaian yang demikian banyak. Ya, slide. Ya, di akhir kami sampaikan alhamdulillah juga bahwa program studi S1 Gizi Kesehatan sudah terakreditasi A dari Lampetekes pada tahun 2019 dan juga terakreditasi AUN pada tahun 2018. Ya, slide. Untuk prodi profesi juga sudah terakreditasi unggul pada tahun 2021, dan pada tahun 2022 kita juga mendapatkan AMI Award ya dari FK-KMK sebagai AMI terbaik ya untuk prodi profesi dietitian. Ya, slide. Mohon doanya Bapak Ibu sekalian, tahun 2024 kita akan lanjut reakreditasi untuk Lampetekes dan juga kita akan maju akreditasi internasional yaitu dengan akreditasi ASIIN. Slide. Ya, yang terakhir kami sampaikan, tentunya kami tidak melupakan sejarah. Ucapan terima kasih kepada Bapak Ibu, kemudian juga kepada institusi mitra, baik itu dalam maupun luar negeri, dan tentunya institusi kami, FK-KMK UGM, yang selama ini sudah mendukung Departemen Gizi, baik itu di S1 maupun di profesi dietitian. Di akhir kata kami sampaikan, karena tadi dengan pantun, saya juga mau coba pantun jadinya ini ya. Makan nasi dengan lauk ikan, ditambah kerupuk menjadi lebih gurih. Kami haturkan beribu-ribu terima kasih. Demikian, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Susityawati atas sambutannya, atas flashback foto-fotonya gitu ya. Kalau yang Gen X kayak saya jadi merasa, aduh saya pernah menawan Bu, di zamannya Bu. Baik, selanjutnya kami akan mengundang dan mungkin mengenalkan kepada terutama adik-adik yang muda-muda semester 1, semester 3, semester 5, semester 7 dan juga mungkin dosen-dosen muda yang belum berkesempatan bertemu secara langsung dengan founding father kami. Kami undang Profesor Dr. Hamam Hadi, M.Sc, S.Gz, S.Gz. Sebetulnya beliau itu sudah menyetujui untuk hadir secara offline dan bergabung bersama kita, tetapi karena ada satu dan lain hal sehingga beliau tidak bisa bergabung bersama kita secara luring dan bergabung bersama kita semua secara daring. Beliau sekarang menjabat sebagai Rektor Universitas Alma-Ata Yogyakarta. Kami undang Profesor Dr. Hamam Hadi, M.S. S.Gz, S.Gz. Disilakan Prof.
Assalamualaikum warahmatullahi wabarakatuh. Apakah suara saya bisa terdengar dengan baik? Baik. Saya ulangi. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. Alhamdulillahilladzi khalaq wa fasawwa walladzi qaddara fahada. Wa nusalli wa nusallimu ala sayyidina Muhammadin nabiyil mustafa wa ala alihi wa sahbihi ahli tuqa wal wafa. Amma ba'du. Yang sama-sama kita muliakan Bapak Dekan Fakultas Kedokteran, Keperawatan, dan Kesehatan Masyarakat Universitas Gadjah Mada beserta jajarannya. Yang kita hormati Ketua Departemen Gizi Fakultas Kedokteran Universitas Gadjah Mada beserta seluruh jajarannya. Para pembicara pada event INHESION 2023 dan juga para alumni, para peserta semuanya yang saya hormati. Pertama-tama mari kita panjatkan puji syukur kehadirat Allah Subhanahu wa taala yang senantiasa memberikan rahmat dan karunia-Nya kepada kita sehingga alhamdulillah di pagi hari ini ya, kita bisa bersilaturahim, ya, bertemu dalam forum yang prestisius ini dalam keadaan sehat walafiat. Bapak Ibu sekalian yang kami hormati, kemarin saya sudah menyampaikan pada panitia bahwa sebenarnya I'd love to come and to see you in person. Ya. Tapi saya mohon maaf, saya kemarin sedikit salah pertimbangan, maksud saya salah perhitungan. Ternyata saya masih on the way back ya, from Washington DC ya, dan baru sampai di Cengkareng pagi tadi sekitar jam 5.30 dan sebentar lagi saya akan melanjutkan perjalanan ke Yogyakarta. Dan oleh itu ya, sekali lagi mudah-mudahan ya, kehadiran saya lewat Zoom ini ya tidak mengurangi rasa hormat saya dan juga tidak mengurangi ya, betapa bahagianya rasa saya ya bisa mengikuti upacara seremonial yang luar biasa ya, yaitu upacara 20 tahun prodi gizi kesehatan. Saya ulangi lagi, prodi gizi kesehatan Fakultas Kedokteran Universitas Gadjah Mada yang luar biasa. Bapak sekalian yang kami hormati, ya tentu ini suatu great honor for me, ya suatu penghormatan yang luar biasa bagi saya bahwa hari ini saya diundang ya itu untuk ikut serta menyaksikan acara seremonial 20 tahun Prodi Gizi Kesehatan Universitas Gadjah Mada sekaligus International Nutrition and Health Symposium 2023. Bapak sekalian yang hormati, ya tadi sudah disampaikan banyak sejarah dan riwayat oleh Ketua Departemen Gizi Ibu Dr. Susistiwati. Ya. Saya malah tidak punya foto-foto itu. Ya. Nanti saya boleh kalau diizinkan nanti saya boleh reproduksi foto-foto itu. Lupa dulu untuk mendokumentasikan sebagian dari foto-foto itu. Benar, satu pun saya tidak punya foto-foto itu. Tapi mudah-mudahan ya nanti suatu saat ya, saya diberi kesempatan untuk mendapatkan reproduksi foto itu ya sebagai bagian dari kenangan yang indah ya selama saya mengawali ya membidani dan ikut serta mengembangkan Prodi Gizi Kesehatan Fakultas Kedokteran Universitas Gadjah Mada yang saat ini sudah luar biasa. Bapak sekalian yang saya hormati, ya, it turned out to be 20 years old, ya, Prodi Gizi Kesehatan Universitas Gadjah Mada. Waktu yang rasanya baru kemarin, ya, bagi saya semua memori itu masih ada. Ternyata sudah umur 20 tahun. Kalau orang Amerika, ya, kemarin kebetulan saya baru bincang-bincang tentang kultur orang Amerika. 20 tahun itu masa sudah dewasa. Kalau itu orang, ya 20 tahun itu dewasa. Aslinya sebenarnya 18 tahun orang-orang Amerika mengatakan dewasa. Di antara mereka sebagian besar sudah tidak mau rely on ya orang tuanya. Tidak mau bergantung pada orang tuanya, dan negatifnya sebagian besar mereka kalau sudah dewasa umur 18 tahun itu nggak begitu mendengarkan orang tua. Termasuk kalau mau harus nikah, mau memilih pasangan siapapun, ya, mereka benar-benar 100% maunya mereka sendiri karena sudah merasa dewasa, ya, it's already independent, ya. From their parent. Kalau umur 20 lebih-lebih ya di antara kultur yang sangat kuat di antara mereka, kalau umur 20 lebih malu untuk tidak independen. Dan kata lain, saya juga insya Allah husnudzon ya, Prodi Gizi Kesehatan Fakultas Kedokteran Universitas Gadjah Mada ini dengan umur yang sudah 20 tahun ini, artinya sudah matur, sudah mature, sudah matang, sudah dewasa. Dan oleh karena itu, dengan pengalaman panjang, ya, dengan struggle yang luar biasa di awal, ya, asam garam yang sudah dimiliki selama ini, insya Allah Prodi Gizi Kesehatan Fakultas Kedokteran Universitas Gadjah Mada ke depan akan lebih berkembang, lebih cepat, lebih maju, dan insya Allah lebih jaya ke depan. Allahumma amin. Bapak sekalian yang saya hormati, masih segar diingatan saya nama Prodi Gizi Kesehatan. Kenapa ada kesehatannya? Berbeda dengan yang lain. Itu tidak lupa dari sejarah pengembangannya. Suatu saat ketika saya mengajukan proposal Prodi Gizi ini, ya, awalnya di Fakultas Kedokteran sudah disetujui sebagai Prodi Gizi saja. Ya. Tetapi setelah sampai di forum senat di universitas, ternyata tidak sedikit para senior yang sudah merasa lebih dulu bergelut di bidang gizi, merasa bahwa jika namanya Prodi Gizi saja, harusnya tidak melekat pada Fakultas Kedokteran. Gitu. Dan oleh itu, saya dengan cukup cepat waktu itu ya, ambil inisiatif agar nama prodinya tidak hanya Prodi Gizi saja, saya matur kepada Pak Dekan, ya, Profesor Hardianto Supono, agar dinamain Prodi Gizi Kesehatan. Dengan demikian, ya, eligible untuk melekat, ya, dan menjadi satu dengan Fakultas Kedokteran Universitas Gadjah Mada, dan sekaligus akan mempunyai karakteristik dan keunikan tersendiri berbeda dari prodi gizi yang lain di Indonesia. Dan oleh karena itu, sekali lagi, ya, insya Allah prodi gizi kesehatan ini di Fakultas Kedokteran ini punya sejarah tersendiri yang itu tidak lepas dari ciri khusus, ya, dan menjadi kekhususan prodi gizi di Universitas Gadjah Mada, berbeda dari prodi gizi yang lain. Dan insya Allah, ya, kekhususan itu, ya, semestinya ke depan terus dikembangkan, ya, sehingga ada distinct, ada sesuatu yang berbeda, ya, dengan prodi-prodi yang lain, prodi gizi yang lain di Indonesia. Dan saya yakin, ya, teman-teman yang sudah hebat-hebat, ya, Bu Susi, Pak Toto, ya, dan juga generasi muda yang saya tahu, ya, sebagian adalah juga alumni prodi gizi kesehatan yang saat ini sudah ikut bergabung, ya, di prodi kesehatan, siap untuk mengembangkan lebih lanjut menjadi prodi gizi yang hebat, ya, tidak hanya memberikan kontribusi di level nasional Indonesia, tetapi saya yakin dengan umur yang sudah dewasa tadi, sudah banyak pengalaman, asam garam, kemampuan adaptasi yang lebih penting lagi, ya, karena bagaimanapun kemampuan adaptasi menjadi satu modal yang harus dimiliki bagi siapa saja, bagi institusi manapun jika ingin survive, ya, ke depan menghadapi berbagai tantangan dan perkembangan, termasuk tentunya adalah, ya, untuk prodi gizi kesehatan. Bapak sekalian yang saya hormati, saya itu merasa mendapatkan anugerah yang luar biasa. Dan begitu juga saya yakin saudara-saudara, ya, teman-teman yang di prodi gizi kesehatan Fakultas Kedokteran Universitas Gadjah Mada, bahwa saya dan saudara-saudara ditakdirkan oleh Allah Subhanahu wa taala untuk terlibat, berkecimpung, bergelut, ya, menekuni sains yang saya yakin, apalagi setelah saya sekian tahun, ya, bergelut sebagai saintis, sebagai dosen, sebagai peneliti, ya, dan juga sekaligus sebagai praktisi, saya merasa prodi gizi kesehatan ini, atau nutrition science sebenarnya yang saya maksud lebih tepatnya, nutrition science adalah sains yang never ending, ya, never ending to progress, ya, ke depan, ya. Kenapa? Karena ketika yang kita jalani, yang kita tekuni itu sesuatu yang tidak pernah lepas dalam kehidupan manusia, nutrition, ya, maka itu artinya, ya, yang kita geluti nggak akan pernah ada akhirnya, nggak akan pernah ada akhirnya, ya. Ya, dan oleh karena itu peluang untuk terus berkembang dan maju terbuka luas, terbuka lebar, ya, dengan adanya modal-modal sejarah, modal kemampuan, modal pengalaman bagi saudara-saudara, ya, para peneliti muda, dosen muda utamanya, ya, ke depan bisa berkontribusi untuk memajukan prodi gizi kesehatan Fakultas Kedokteran Universitas Gadjah Mada. Bapak sekalian, coba lihat gitu. Tidak ada kata yang Allah sendiri, ya. Allah sendiri itu menitik beratkan, ya, pada bidang gizi itu. Maka Allah berfirman, A'udzubillahi minasyaitonirrajim, falyanzuril insanu ila ta'amih, gitu. Ya. Maka sebaiknya manusia itu melihat kepada makanannya, apa yang dimakan. Dan makanan itu adalah sentral dari nutrition science. Karena ya tidak ada proses digestion, tidak ada proses absorption, tidak ada proses utilization, ya, unless we have available food. Kecuali kita punya makanan yang tersedia. Dan kata lain, sekali lagi, saya ingin mengucapkan selamat pada saudara-saudara, ya, para dosen, para alumni, dan para mahasiswa gizi. Ya. Kenapa begitu? Ya, karena insya Allah saudara-saudara sudah on the right track. Anda ada pada jalur yang sangat tepat, jalur yang tidak akan pernah ada akhirnya sampai kiamat. Ya. Anda punya peluang lebar, luas untuk terus bergelut, mengembangkan, dan memajukan ilmu pengetahuan khususnya di nutrition science. Dan dengan demikian, sekali lagi, insya Allah nggak boleh ada rasa putus asa, nggak boleh ada rasa kecil hati ke depan mau apa, ya. Tapi siapapun yang terlibat dalam bidang gizi, ya dosennya, ya praktisinya, siapapun itu yang bergerak di bidang gizi, tidak akan pernah kehilangan job, tidak akan pernah kehilangan langkah untuk maju dan terus berkembang. Dan sekali lagi oleh karena itu, saya mengucapkan selamat, ya, ulang tahun yang ke-20, ya. Selamat bagi Prodi Gizi Kesehatan Fakultas Kedokteran Universitas Gadjah Mada. Semoga ke depan terus berkembang, terus maju, dan terus lebih jaya. Tentu, ya, saya sebagai bagian tak terpisahkan dari Prodi Gizi Kesehatan, ya, meskipun saya tidak lagi, ya, seintens dulu di Fakultas Kedokteran Universitas Gadjah Mada, tetapi hati saya masih ada di sana, dan doa saya akan selalu bersama Anda dan bersama Prodi Gizi Kesehatan Fakultas Kedokteran Universitas Gadjah Mada. Bahwa saya tidak di sana tidak berarti saya tidak mencintai, tapi ambillah pelajaran penting. Insya Allah justru adalah kesempatan biar generasi muda tidak ragu, tidak rikuh, ya, lebih independen, ya, mengembangkan prodi kesehatan Fakultas Kedokteran Universitas Gadjah Mada. Dan saya sangat yakin bahwa saudara-saudara mampu untuk terus mengembangkan, menjadi bagian penting yang tak terpisahkan dari proses pembangunan di Indonesia dan juga proses pengembangan kehidupan manusia dimanapun itu menuju kualitas kehidupan yang lebih baik ke depan. Bahagialah saudara-saudara yang terlibat di Prodi Gizi Kesehatan, ya, dan juga bagi generasi muda, lebih lagi yang mengembangkannya punya tujuan bukan hanya untuk membangun kehidupan yang lebih baik di dunia, tetapi keterlibatan Anda di situ juga merupakan bagian upaya untuk membangun kehidupan yang lebih baik nanti di akhirat. Dan insya Allah semua itu akan menjadi barokah tersendiri dan kemanfaatan buat saudara secara pribadi, tapi juga buat orang lain yang selalu menanti kehadiran para nutrition scientist, para praktisi bidang kesehatan baik di Indonesia maupun di dunia manapun selama itu masih hidup di dunia ini. Demikian yang bisa saya sampaikan. Sekali lagi luar biasa, ya, buat Prodi Kesehatan, ya. Selamat sekali lagi ya buat Prodi Kesehatan dan seluruh pihak ya, seluruh dosen, seluruh alumni dan mahasiswa ya Prodi Gizi Kesehatan Fakultas Kedokteran Universitas Gadjah Mada. Selamat sekali lagi dan insya Allah semuanya akan menjadi berkah untuk kita semua. Wallahul muwaffiq ila aqwamit thoriq. Kurang lebihnya mohon maaf. Assalamualaikum warahmatullahi wabarakatuh. Mohon pamit.
Waalaikumsalam warahmatullahi wabarakatuh. Safe flight, Prof Hamam kembali ke Yogyakarta. Terima kasih. Baik, terima kasih sekali lagi kepada Prof Hamam yang telah berkenan hadir secara online dan memberikan refleksi virtual kepada kita semua dan juga semangat yang sudah dibagi kepada kita semua. Semoga dapat menjadi pembelajaran di masa depan untuk kemajuan Prodi Gizi Kesehatan FK-KMK UGM. Safe flight, Prof Hamam kembali ke Yogyakarta.
Ya.
Terima kasih.
Terima kasih, saya mohon izin pamit keluar.
Prof Hamam, Nun Sewu masih bisa bergabung 5 menit, 10 menit karena kita akan potong tumpeng.
Siap, siap.
Baik Bapak Ibu sekalian, kita akan sampai di sesi puncak 2 dasawarsa yaitu pemotongan tumpeng. Kami undang seluruh pengelola Departemen Gizi Kesehatan, Dr. Susityowati DCNMKes, adik-adik mungkin sekalian dibawa ke sini nggih. Oh, mau dengan meja aja. Pakai troli aja gitu. Troli aja gitu, Dek. Oh, meja ya udah. Yang berasal dari luar Jawa mungkin tidak tahu apa itu tumpeng. Tumpeng itu katanya Google ya, itu yen metu kudu mempeng katanya gitu. Jadi artinya kalau dalam bahasa Indonesia itu ketika lahir atau ketika keluar itu harus bersungguh-sungguh dan semangat, fokus dan tidak putus asa. Hidangan ini juga bermakna ucapan syukur ataupun kebahagiaan. Oleh karena itu kami menghadirkan hidangan ini di acara 2 dasawarsa Prodi Gizi Kesehatan. Kami undang seluruh pengelola Departemen Gizi Kesehatan, Ketua Departemen, Sekretaris Departemen, Ketua Program Studi S1 Gizi Kesehatan, Sekretaris S1 Gizi Kesehatan, Ketua Prodi Profesi Dietitian, juga kepada Dr. Toto Sudargo SKM Kemkes, Dr. Emi Huryati Mkes untuk maju ke atas panggung di sini. Dr. Memi ada? Oh ya, Dr. Siti Helmiati juga hadir, silakan. Nanti saya boleh minta hadirin untuk nyanyi Happy Birthday, boleh ya? Baik, jadi nanti pemotongan tumpeng akan dilakukan oleh Ibu Ketua Departemen, Dr. Susityowati DCNMKes selaku Ketua Departemen bersama, oh Dr. Lili, ayo Bu, maaf Bu. Dr. Lili sekalian maju Ibu. Ini tidak akan potong tumpeng kalau Bu Lili belum maju Bu. Baik, jadi pemotongan tumpeng ini nanti akan dilakukan oleh pengelola begitu ya, bersama dengan Ibu Dr. Emi Huryati Mkes. Beliau adalah Ketua Departemen periode 2009 sampai dengan 2013 dan Bapak Dr. Toto Sudargo Mkes adalah Ketua Departemen periode 2014 sampai 2019. Bukadep. Bareng-bareng tapi ya kali semua ya. Mungkin merapat biar fotonya bagus ya. Ya. Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday. Happy birthday Gizi. Oh, satu lagi mungkin ya. Potong tumpengnya, Potong tumpengnya sekarang juga, sekarang juga, sekarang juga. Ibu satu lagi Bu, tumpengnya satu lagi Bu. Yang pertama, tumpeng yang pertama kami serahkan kepada Prof Hamam karena hadir secara daring. Oh belum? Hadir secara daring, jadi kami wakilkan kepada Ketua Program, ke Pak Toto? Atau ke siapa? Oh baik, kami wakilkan ke Pak Toto, enggak apa-apa ya Prof?
Siap, siap.
Kami
Terima kasih, terima kasih.
Kami
Terima
wakilkan.
kasih.
Baik. Pak Sudadi udah nggak ada? Oh, udah kangen. Baik, sudah ya. Foto bersamanya apakah sudah? Foto bersama dulu Ibu. Ini Prof Hamam bisa kelihatan nggak ya dari foto? Nggak bisa ya? Oh bisa, oke.
Ada di atasnya itu.
Baik. Selain tumpeng ada satu lagi, gift untuk Prof Hamam. Dan karena sekali lagi beliau hadir secara daring ya, jadi mungkin kami akan serahkan secara diwakilkan begitu ya ke Bu Nuning. Bu Nuning mohon maju ke depan.
Siap, siap, siap.
Bisa.
Terima kasih, terima kasih.
Selanjutnya adalah sesi penyerahan cindera mata dari Ketua Departemen Gizi Kesehatan Dr. Susetyowati DCN-MKes kepada Prof Hamam Hadi, tapi karena hadir secara daring dan akan diwakilkan oleh Ketua Prodi Gizi Kesehatan FK-KMK UGM, Ibu Erdwi Budiningsari Ph.D. Silakan Prof. Besok Bu Nuning bertanggung jawab untuk mengantar ke Alma Ata Prof.
Siap, siap, siap. Sekali lagi terima kasih pada Ketua Departemen Gizi Fakultas Kedokteran Universitas Gadjah Mada, Ibu Susi dan seluruh jajarannya. Terima kasih kepada panitia. Ya, mudah-mudahan ini semuanya meneguhkan hati saya ya untuk terus bersama teman-teman semuanya ya di Prodi Gizi Kesehatan Fakultas Kedokteran Universitas Gadjah Mada, tapi juga kebersamaan saya dengan teman-teman ya, pecinta gizi di seluruh Indonesia. Mudah-mudahan mohon doa restu ya, pada teman-teman semuanya, terutama yang hadir. Mudah-mudahan saya selalu diberikan kesehatan, ya, umur yang lebih barokah dan lebih bermanfaat. Allahumma amin. Terima kasih sekali lagi ya. Saya mohon izin, mohon undur. Ya, saya
Baik, Prof.
segera akan masuk gate, insya Allah ya, terus ke Jogja. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Prof Hamam. Ibu, ini ada foto semua dosen di depan gitu nggak ya? Oh iya, ini mungkin sesi foto dulu ya sebelum saya close dan mungkin langsung ke acara INHESION ya. Ini gimana Mas Joko? Foto, oh yang dari sini Mas Joko naik di sini kali ya? Fotonya gimana? Ya, Mbak Dian mungkin atau Bu Lili mungkin merapat ke sini nggih biar kelihatan di depan semua ya pengelola dan dosen. Oh Mas Fahmi ada juga. Mas Fahmi tadi lihat fotonya tahun 2000 sekian nggak Mas? Masih langsing dan sungguh lah ya menawan di zamannya. Ayo Bu Lili, Bu Emi maju ke depan semua aja ya biar kelihatan di tengah gitu. Bu Jana, Bu Neni, dosen yang di belakang nanti nggak kelihatan di foto loh ya. Oh, saya nge-MC aja.
Mbak, Mbak,
Oh iya, boleh,
Mbak,
boleh, boleh.
Mbak.
MC boleh foto ya, siap.
Orang nampak sini jadi satu. Sini jadi satu sini. Karena udah lanjut sini.
Gimana Mas?
Sini jadi satu sini.
Oh, yuk Mbak, pindah. Nggak kelihatan.
Ya.
Harus kelihatan kita. Kelihatan nggak Mas?
Oh, kelihatan kalau di sini.
Pinjem dulu. Mas di ya Allah 1 2 3 Mas.
Ya. Kita hitung. Satu, dua, tiga. Ini tangannya ke atas semua. Ya. Ya. Ya, sip, sip.
Terima kasih. Masih ada foto lagi nggak Mas? Udah ya? Kok kayak belum kerasa gitu ya Mas? Baik Bapak Ibu sekalian, demikianlah serangkaian acara peringatan 20 tahun perjalanan Prodi Gizi Kesehatan FK-KMK UGM. Setelah ini acara akan dilanjutkan acara INHESION. Kami serahkan kembali ke Sabrina.
Ladies and gentlemen, I trust that you found the 2 decades ceremonial to be a meaningful and reflective journey. Now, as we transition back to our regular symposium agenda, I would like to extend my deepest appreciation to Miss Umi, who expertly guide us through this significant occasion. Their insight, dedication, ability to connect with the essence of this ceremony were truly commendable. We are approaching a juncture in our programs that promises both relaxation and engagement. Following the current session, we will be taking a brief pause for a well-deserved coffee break. It will be held in the auditorium right outside of this building. Due to food and drink prohibition, please do not bring your food and drink inside. Thank you for your attention, and I look forward to seeing you after the coffee break. We are going to move to our main agenda. Before we start, I would like to introduce our moderator, Ms. Bianda, who will lead the discussion today. Ms. Bianda Aulia, her education background is Bachelor of Nutrition and Health, Master of Science, Clinical and Public Health, Nutrition, and ongoing dietetics programs. She is listed currently as a research assistant at Department of Nutrition and Health, Universitas Gadjah Mada. Ladies and gentlemen, please welcome our moderator, Ms. Bianda Aulia, Sarjana Gizi, Master of Science.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, honorable speakers, distinguished guests, and ladies and gentlemen that are participating in INHESION today. I welcome all of you to the lecture, the Symposium lecture of INHESION 2023. My name is Bianda Aulia, and I will be moderator for today's lecture. Before that, I would like to tell you that today's speaker will be Dr. Noraida Omar, Dr. Jati Kusuma in the first panel of today. And the Q&A session will take place after the second lecture by Dr. Jati Kusuma. So without further ado, let me introduce our first speaker, Dr. Noraida Omar. Is there going to be a CV that is presented? Okay, while we wait, I would like to tell you a few things about Dr. Noraida Omar. She is currently a lecturer in the Department of Dietetics, University Putra, Malaysia. She obtained her Ph.D. in Nutritional Science Dietetics from University of Surrey in 2015. She is currently also an active member of various scientific committees. Can you scroll? Okay. She is serving as a council member for Malaysian Society of Body Composition and also as a member of Malaysian Dietetics Association. Dr. Noraida Omar also received multiple awards throughout his academic career, including SLAB scholarship from the Ministry of Higher Education Malaysia and Excellence in Service Awards by UPM. Dr. Omar's area of research is geriatric malnutrition and also food service management. She has authored more than 50 articles, and her most recent publication is a protocol of her project titled The Logical Framework for Hospital Food Service to Prevent Malnutrition Among Geriatric Patients in Hospitals. Ladies and gentlemen, we may have some practitioners and also dietitians among the audience. We know that dysphagia or difficulty in swallowing is a common problem in hospital settings, which leads to reduced food intake and subsequently malnutrition. That's why we have Dr. Omar here with us today to give her insight on dietary modification and food service management to improve food intake and minimize food waste for patients with dysphagia. Without further ado, help me welcome to the stage Dr. Noraida Omar. while we wait for the PowerPoint, maybe Dr. Omar will give a, like.
Alright, okay. Assalamualaikum warahmatullahi wabarakatuh. Very good morning. Good morning. Okay, thank you, Miss Bianda, for very kind introduction. I'm Dr. Aida. Can you call me Ibu Aida? I'm from UPM, okay, University Putra Malaysia. First of all, thank you UGM for invited me, Ibu Nuning, Ibu Susi, yeah, and all Ibu Farah, and all department members, all the members of from the UPM. Send the very warm regards to all of you. Yeah. Okay. So the topic given to me, dietary modification and food service management to improve food intake and minimize food waste of the patient with dysphagia. Okay. Okay. It's not function. Okay, like the Mrs. Moderator introduced me, I'm obtained my PhD from University of Surrey. I work on the research among geriatric patients, comparing UK with Malaysian. So in UPM, my research focusing on clinical geriatric nutrition and also food service management. I also manage the clinic diet Warga Emas. It's a geriatric clinic diet in Hospital Sultan Abdul Aziz Shah. It's a UPM hospital. Yeah. So it's not function. Yeah. So this is my research area: geriatric clinic, geriatric nutrition and food service management. Okay. Next slide. Okay, this is the learning outcome for today. So to understand dysphagia, we need to understand the swallowing process. We also need to understand what actually the dysphagia. Yeah, hospital diet, texture modified diet, medical nutrition therapy for dysphagia, the challenges and also the recommendation. Okay. Next, so to understand the swallowing process. Okay. Okay, so realize or not, so swallowing, we always swallow. Okay, we swallowing the food, drinks, the air, and also the medication. Okay, it's a voluntary process. Voluntary meaning that you eat food, you drink the beverages, and you eat the medication. It's a voluntary, tiada paksaan. Yeah. It involves 3 phases. Yeah, phase 1 is in oral place, so it's a voluntary, tiada paksaan. Okay. Second phase in the pharyngeal is a voluntary process. Yeah, and the third phase is the esophageal, is a involuntary. To understand the swallowing process, is involve 3 phases. So next. So these 3 phases start with the oral phase. We consume food, we drink drinks, and also we consume the medication. It starts from the oral. So to understand the oral, you need to know the anatomy. Okay, it involves the tongue. Okay, the hard plate, the soft plate, the pharynx, and also esophagus. Okay, so next. So when you consume food, the function of your tongue, when you bite food, okay, and then it will lead to the bolus of food, and its function of our tongue to push to the pharynx phase. So after going on to the pharynx phase is the wave of the peristalsis force the bolus between the tonsillar pillars and then lead to the draw to the posterior nerve and also respiratory, voluntary, and then the role of the vocal cord and larynx, the pulse upwards, converting the airways and strengthening the esophagus open. So this is the second phase. So next. So the third phase involves the esophageal. So from the larynx goes to the esophagus, from the esophagus to the stomach. So it's a role of the peristalsis process that move our bolus food, yeah, from the larynx to the esophagus leads to the stomach. Okay, so the problem of the swallowing occurs in these three phases. Okay, so next slide. So to understand the dysphagia, so dysphagia is a swallowing disorder that involves these three locations, either in oral, pharyngeal, and or in the esophageal. Okay, so when we having problem with swallowing, it's meaning that it will affect our food intake, the nutrition. We also consume the drink, our hydration status, and also the medication intake. Yeah, so dysphagia is not only is common among elderly patients because of the aging process, but it also appears in the children as well. Okay, so yeah, prevalence of dysphagia, if you see this table, is very common among older people that age more than 65, is about 30%. Those elderly patients living in the institution, meaning that in the hospital, in the care home, nursing home, is about 50%. Okay, patient with the neurodegenerative disease, the dementia, yeah, about 80%. And also head and neck cancer is about 75%. I googled, okay, to find out the prevalence of dysphagia among Indonesian. So this one I found is about 63% among children. So this figure shows that dysphagia not only common in older adults, but we usually see among geriatric patients, but it also appears in the children as well. Okay, can you imagine children? It requires suction, okay? So suction of the breast milk. If they have the problem to swallow, it will lead to the deterioration of the health, yeah? Okay, so this is the causes of the dysphagia. So for the neurological causes, the stroke patient, the Parkinson disease, multiple sclerosis, this the patient with dementia, okay? Motor neuron disease, and also brain tumor for aging due to the weakness of the muscle. In our oral cavity, we have the muscle. Yeah? If the muscle is very weak, the food that we eat cannot be swallowed. Yeah? And some of the congenital and development condition common among pediatric patients that lead to the learning disability, patient with the cerebral palsy, patient with the cleft lips and also palate. Okay, pernah tengok patient with cleft lips? So improper of the oral function, so will worsen the condition, especially the process of eating. Yeah, and others, patient with the COPD, chronic obstructive pulmonary disease, they have a difficulty to breathe during the eating time that lead to the swallowing problem. Okay, so this is the complication of dysphagia. If we have the swallowing difficulty, so a patient usually experience this, coughing and choking during eating. During eating, if patient experience choking, so it will lead to the bronchopneumonia. So in our oral here, not only food to go to the stomach is also in our airways. Tersalah masuk saluran pernafasan, it will lead to the aspiration. It's very dangerous. It will lead to fatal. Yeah. So dehydration and inadequate of the fluid intake, malnutrition, okay, poorer long-term outcome in the hospital actually may lead to the longer hospital stay, poorer quality of life, okay, poorer prognosis, and may lead to the mortality. Okay, increase length of hospital stay, quality of life, increase rehab time, and need the long-term assistance, especially the assistance with feeding. Okay, increase mortality and also increase the healthcare costs. So to screen the dysphagia is not role of dietitian. Dietitian is not diagnose the dysphagia, okay? But we need to know, okay, how dysphagia is being screened and also diagnosed by using the 8-item eating assessment tool. We call it EAT-10. Okay? It's a simple of 10 questions to answer, then we can screen the risk of dysphagia, as well as the water test combined with the pulse oximetry. Okay, so this is the eating assessment tool, it tests. Okay, this is the question, 10 question, and then we can grade the scoring from 0 to 4. 0 meaning that patient don't having that eating problem. Okay, if patient having the problem, we can rate from 1 to 3, 1 to 4 depending of the severity, and then we will total up the score. Okay, this is the screening tools. Okay, but as a dietitian, when we meet the patient, we also can screen the patient based on their hard swallow. Okay, we ask patient, okay, please dry swallow without any food or drink, and then we want to see the movement of the food or our air from the oral to the larynx and also to the esophagus. Okay, if don't see any movement, meaning that there are no pressure. Okay, no pressure, and then we can define this patient having difficulty in swallow the food. Yeah. So, hospital diet. Okay. Hospital diet in Malaysia, we have manual of hospital diet. Okay, so this one developed by our Ministry of Health. Okay, this is the recent one we developed in 2016, published 2017. Okay, but in the other respective hospital, especially the outsourced company, when you learn about food service, they are in-house and outsourced. Outsourced meaning that we cater the food service to the outside company to handle the food to our patient. So that company also will have their own hospital manual. They will adapt the hospital manual from the MOH and then having their own hospital diet manual. So why I'm telling you this? Because as a dietitian, we need to know. We need to know how to develop the menu for the respective disease. Okay, patient with the dysphagia may have their own specialized diet. We call it texture modified diet. Okay, in the manual of the hospital diet, they have a variety of diet: the normal diet, pediatric diet, therapeutic diet, and as well as the texture modified diet. So texture modified diet, we provide the selections depending on the patient ability to swallow and also to chew. Yeah. From the puree, blended or blenderized diet, if you can see here, the food, all of food being blenderized, we blend. Okay, the green one is the vegetable. Yeah, the brownish at the top is a chicken. Yeah, okay, chicken masak kurma. Okay, and then we blend 100%. So this one is the rice, so we blend. Yeah, so this one is a puree, meaning that we provide the rice or rice porridge with the cooked vegetable, and protein must be soft and not spicy, and then we blend. We cook first. After cooking, we blend. Yeah. So vegetable without skin and seed are used. Rain fruit juice is suitable for this diet. So everything on the tray must be blenderized. That's we call it puree diet. Yeah. So for patient having minimal chewing, we have the different diet. We call it mixed porridge. Yeah. Mixed porridge, how is different with the puree? Is a soft diet, but we provide a different texture, especially for the protein. If you can see here, the protein we carik-carikkan to the small pieces. We want to assist the patient to chew and also to swallow. Yeah. So mixed porridge is a rice porridge cooked with protein and vegetables. Is a balanced meal, added with small amount of oil, but should not a spicy one. Yeah. So boneless protein, all the protein must be boneless, okay, because the bone will having risk of the choking as well. Okay. So vegetables need to thinly slice and cook until soft and moist. Okay. Other choices is a mixed diet. So mixed diet requires patient to minimal chewing. Okay, so mixed diet, rice porridge, okay, protein dish and vegetable are cooked until soft but not spicy. We not blender the protein and also veggie, but we cut into the small pieces, okay, to assist in feeding. Okay, soft fruits are served with the soup or gravy. Yeah, so this is the some of the selection of the texture modified diet. Okay, so everything is not preferred by patient. So this is the issue of the texture modified diet. So the prevalence of plate waste in the hospital is up to 65%. If you go to the literature, it's up to 65. The plate waste is higher if the plate waste more than 30. We consider it high. Yeah, so 65 is a common. It's very high in the hospital. But if we compare regular diet, standardized diet or normal diet with the texture modified diet, patient will have higher plate waste with the texture modified diet compared to the standard one. So when we screen more, we can see that with the blended diet having the higher percentage of plate waste compared to the mixed diet and also mixed porridge. So this is the issue. We provide the specific meal. We want to help patient to eat, but at the same time, patient not able to finish the meal, and then leading to inadequacy of intake. With patient having inadequacy of intake, it leads to the poorer nutritional status and having higher risk of the longer hospital stay and higher cost as well. Okay. So the other issues with the texture modified diet, so there are no specific guideline. So every hospital have their own texture modified diet, but and also the hospital staff also cannot differentiate between which one, okay, what actually the standardized of the mince and moist, okay, easy to chew and so on. There are no standard guideline. That provide the uncertainty of the dietary provision among the caregiver and also food handler in the hospital itself, okay, that lead to the poorer acceptance of the patient due to meal presentation and also aesthetic. Okay, when we eat the food, we actually eat with our eyes first. Okay, that's meaning that the food presentation must be at their own best to attract patient to eat, especially patient yang tengah sakit. Okay, so we eat our food with our eyes first, with the presentation. Then comes the aroma, the smell, and then it attracts us to eat. Yeah, but if the presentation fail, especially the puree diet, so it lead to the poor acceptance. Okay, so if patient did not accept the food that we serve, it will lead to the poor mealtime satisfaction, patient tak makan, having the compromised nutrition intake. If longer compromised nutrition intake, it will lead to the compromised nutritional status, as this group of patient requires greater attention and encouragement from the hospital staff, okay, because malnutrition is 1.2 times higher for those who are having texture modified diet compared to the standard diet. Okay, so malnutrition also reported higher, 50% among patients with dysphagia. Okay, and then this condition lead to the poorer long-term clinical outcome, having easily to high risk of the respiratory infection. Makan tak cukup protein will lead to the decreased skeletal muscle mass. Yeah, longer hospital stay and also higher mortality rate. So, medical nutrition therapy for dysphagia. So to manage this kind of patient requires a collaborative, is a multidisciplinary teams. Not only dietitian, nutritionist to come out with the menu. It's also a collaboration with the doctor as well as the speech therapist, to diagnose the dysphagia is not the dietitian role, but as a dietitian or nutritionist, we need to know which kind of patient having higher risk of the swallowing problems. Okay, so speech therapists with diagnose, okay, with all this method, this is the role of nutritionist and dietitian to modify, to do the dietary modification. There are two things we, in the MNT for dysphagia, we modify the texture and also we modify the consistency of the liquid. So, from the literature, we know that the key issues among dysphagia patient is having weight loss, yeah, anorexia, and also dehydration. So, medical nutrition therapy, or in the short form MNT, is really important to maintain and also to ensure adequate nutrition and hydration status among patients, okay, to implement the correct and safe texture modified diet and also liquid consistency upon the speech therapist recommendation. Speech therapist will decide which level that patient able to swallow, yeah, and also maximize the nutrient intake. We provide the more appetizing and palatable, well presented, while maintaining the self-eating to prevent the aspiration and also choking. So this is the three goals of the dietary management. So have you heard about IDDSI? International Dysphagia Diet Standardization Initiative. It's recently developed, okay, in Malaysia. We also work on this to improve our menu, yeah. So International Dysphagia Diet Standardization Initiative, IDDSI, was found in 2013. Dia baru jumpa 2013, okay, because this, we want to facilitate all the healthcare providers to decide which consistency, which texture of the food which safe to the patient, yeah. So for the IDDSI, so yeah, developed 2013. We aware of the present is 2017. Okay, so the team will prepare the work, the menu in 2018 and adopt the IDDSI in the hospital in 2019. And then the process is keep on going. So I am one of the volunteer from the Malaysia for the IDDSI Asian. Yeah, we still work on it to give the awareness, okay, and then how the practitioner, the healthcare provider will implement and adopt in the hospital. So using this framework, so they have 7 level. So 8 level ranging from 0 to 7, so including the food and also the drink. Okay, the drink from level 0 to 4, the foods is level 3 to 7. Okay, so this is the framework, okay. 0 is for drink until 4, different consistency, from thin, slightly thick, mildly thick, moderately thick to the extremely thick. And then if we refer to the food, the texture of the food is ranging from the 3, so it's a liquid-side, is similar consistency with the moderately thick, yeah. And then puree diet, similar consistency with the extremely thick, minced and moist, soft and bite-sized, easy to chew, and also the regular diet. Okay, so we need to know which level. So it's from 0 to 7. Yeah. Okay, it's very hard because it requires skill and also competency to define. So this kind of the liquid is level 1 or level 2 or level 3. Yeah, it requires training. So if you go through to the literature, so previously we have the nectar-like, honey-like, and pudding spoon-thick. So we have a spoon examination. So I will elaborate further later how to transform from the usual dysphagia diet to the IDDSY. Pernah dengar ke nectar like, honey like? Ya? Okay. So, nectar like is similar to level 2. It's a mildly thick. Yeah? Honey like is a level 3. Yeah? It's a moderately thick liquid. Okay? Level 4 is a pudding like. Like a pudding. So this one is a extremely thick puree. So speech therapists will decide which level that's suitable to the patient. And then we will prepare the meal to the patient depending on the prescription from the speech therapist. Can you move the slide? Oops. Sorry.
Sorry for the inconvenience. There's some error in the technical issue.
Okay.
Maybe we can continue now.
Level 0, the previous slide, please. Okay, we go one by one to which level. Level 1 is for the liquid. We start with the thin. Yeah. So thin level 1. So it's like a flow of water. Yeah. If you drink a water, it's like a water. It's very fast flow. Can drink through any type of the teeth, nipple, straw, or for appropriate for age and also skill. So this one indicated for patient who have the functional ability to self-manage the liquid from all time. Yeah. So level 1 is a slightly thick. So this description for this level 1 is thicker than water. Okay, so requires little more effort to drink than thin liquid. We can use the assistance from the straw, shrink, yeah, and teeth nipple. Okay. So this one often used to the pediatric population as a thickened drink that reduce speed of flow because the level 0, the liquid is moving so fast, higher risk of the choking. Yeah. So level 2 is a mildly thick. Yeah, mildly thick. We use we assess the flow of the liquid from the spoon. Yeah, so it's a sippable, pour quickly from spoon but slower than thin drink. So it requires mild effort to drink this thickness through the standard broad straw. Yeah. So level 3, moderately thick. Yeah, for this moderate thick, patient can drink from a cup. So, boleh minum daripada cawan. Moderately effort is required. To standard bra or white bra straw, kita perlu straw yang lebih besar sebab the drink is moderately thick. Yeah, cannot eaten with fork. If you use fork, the texture, the consistency cannot hold with the fork. Yeah, so there are no oral process or chewing required. Tak perlu chewing. Only need to swallow. The smooth of the texture, there are no bites, no lumps, no fiber. If you blend the fruits, meaning that you need to blend it well, there are no fiber inside the juice. Okay, so the physiology rationale for this one, because of the if the tongue control is insufficient to manage the mildly thick, so then the liquid size moderately thick may be suitable. So more time, this one allow more time for the oral control. Yeah, if you compare with the level 0, the liquid moves so fast you cannot control. Yeah, okay. So this is level 3. If you can see that we're using the fork test, the liquid is not moving so fast. Yeah, it will appear at the fork as well. So level 4. Can you move to level 4? Okay, level 4 for the food is a puree, for the drink is a extremely thick. Okay, so for this level, so kalau kita nak bandingkan macam makanan untuk bayi lah. Yeah. So usually eaten with a spoon. So if you use fork, is also possible because this texture the fork can hold. Yeah, so cannot be drink from a cup because it doesn't flow easily. It's very thick. Yeah, you cannot drink that. So cannot be sucked through a straw. This one does not require chewing, but can be piped, layered, and mold because it's retained its shape. Selalunya to improve the presentation of the puree diet, we use the mold. Yeah, we blend the meal, we blend the diet, and then we use the mold to improve the presentation. Okay, so to test this one, we usually use the shrink test. Okay, we use the shrink test. I think we have next one, please. Okay, so this is the test. Yeah, to indicate which level 0, 1, 2, 4. We use this shrink. We remove the caps, okay, and then we close the flow at the bottom, yeah, and then we put the liquid inside the shrink. We fill the shrink until 10 milliliter line. Okay, then it's stuck. And then we open the flow at the bottom, and then we measure the timing. How many times requires the liquid to flow throughout the string. So that by doing this, we can decide which level, 0, 1, 2, 3, or 4. Yeah. So can we move on to the next? We skip this video, please. Okay, next. Okay, next. Okay, next. Okay, next. Okay, next. Okay, so after level 4 is a level 5, is a mince and moist. Pernah tengok tak mince and moist? Have you seen mince and moist? So mince and moist is a better version from the puree. Yeah. So this is the output from the mince and moist. The food, especially the protein and also the vegetable we mince. Okay. So but the indicator of this diet must be moist. Yeah. So can be eaten with a fork or spoon. Would be eaten with the chopstick in some cases. Okay. Can be scooped and or shaped. Okay, on a palette, so we use the mold to improve the presentation. So the food must be soft and moist with no separate with liquid. If you can see here, there are no liquid appear here. So this meaning that this diet is mince and moist. Yeah. Next. Okay, so mince and moist. So is for patient that doesn't requires biting, yeah, because it's already mince and moist. Minimal chewing required. The tongue force alone can be used to separate the soft and small particle in the texture. So it's an indicator for patients who are having missing teeth and poorly fitting dentures. Okay, next. Okay, level 6 is a soft and bite size. Okay, if you can see from the picture here, it's a bite size. We cut it into the instruction. So the instruction for the pediatric is the size should be 8 mm times 8 mm. that small size. So for adult is 15 mm over 15 mm. That's the standard size for the soft and bite size. So this kind of meal can be eaten by fork, spoon or chopstick, can be mashed or broke down with pressure from fork, spoon and chopstick. Okay? Yeah. So level 8, sorry. Skip. So level 7, easy to chew. For easy to chew, it's like a normal diet, but the type of diet must be easy to chew. Yeah, there are no standardization on the size of the protein, but the protein must be tender, meaning that can easily separated by fork or by spoon. Yeah, so it does not include the hard, tall, chewy, fibrous, and may include the dual consistency or mixed consistency fruit and also liquid. So this is the easy to chew test. If you take the food can easily separated by forks, okay? And also if you press the fruit is retained, press after you take out the fork. So this is easy to chew. Okay? So the slide mentioned can maintain dual consistency, meaning that this is example of dual consistency in one meal. We have a hard and chewable food like a cornflake, but we eat with milk. Is a dual consistency. How patients eat this kind of dual consistency is we take both on our spoon, we take the cornflake with milk, and then when we enter our oral, we will drink the milk first, and then after that we will chew the cornflakes. And now you realize how you consume the cornflake. Yeah? So it requires dual texture and also consistency. Okay? So I need to move fast. Okay. Next, please. Okay, this is the food that you need to avoid. So the hard and dry texture, crispy texture, fibrous tongue texture like a pineapple. Next slide, please. A chewy texture like lollipops, okay, marshmallows, crunchy texture like raw carrots, okay. So pipe seed and the white part of the fruits like orange, you need to take out all the seeds, okay. Next. Skin, husk and outer shell like a pea shell, brains and psyllium, the stringy texture, greens, beans, and also bone or gristle, like chicken bones and fish bone, we need to take out before we serve to patient because patient higher risk of choking. Yeah. So next slide. Okay, next slide. Okay, so this is role of nutrition support. If we provide this kind of 0 to 7 option for the patient, but patient still cannot swallow, so comes the role of the nutrition support. Yeah, meaning that patient oral thing is not functioning well, come to the nutrition support to meeting the nutrition requirement. So usually we use the enteral feeding from the gastric feeding for the short or long term, okay. In order to meet the nutrition needs, okay, we also can opt for the continuous or bolus feeding. Yeah. Okay, so this one we can skip, please. Okay. It's okay to give ice cream, chocolate to patient if patient can swallow. So now I would like you to Google this IDDSY SI. So for further reading, they have also from the YouTube channel, you can see all the videos that I share and a lot of video for your guidance. Next. So this is the IDDSI website. Next. So IDDSI website also have the apps for your mobile phone. So please download and use as your own reference. So next. So this is the challenges, okay? So challenges, we already have the standardization. The team is work hard to meet the standardization throughout the care setting. So the challenges is based on this study mentioned that the knowledge of the texture modified diet is very limited. Yeah? But the staff, the food service staff is have a good and also good attitude and also having good practices towards that. So that's meaning we need to have a awareness program among food handler, especially in the hospital setting. So next. This is recommendation how to improve the texture modified diet. So as I said, education of patient, family and also carers, and also regular staff training. So use of the mold and also nozzles to enhance the meal presentation. This requires a lot of hard work. Yeah? So proper, interesting and palatable menu for patient, the menu need to improvise. Proper feeding technique, we need to educate the carer and also staff how to help patient with the proper position before we feed the patient. Yeah? And also requires multidisciplinary team from the speech and language therapists, and this kind of patient requires close monitoring from the doctor and also dietitian. So some recommendation for the future research, okay. So the research among this topic very limited, okay. Focusing on hospital setting, it requires a lot of work in other healthcare setting. On strategy, special strategy for the blenderized and pure diet, on patient acceptance of the thickened fluid and also beverages. Most of the study focusing on the texture. Yeah, so cost effective for the fortification and also collaborative with the food service to implement high quality and also nutritious foods for this dysphagia patient. So as a conclusion, to manage this to manage dysphagia, it requires a collaborative multidisciplinary team. You need to have a good communication between other healthcare professionals so that the safe of the patient can be met. So to save of the patient, we need to have a good knowledge how to standardize the menu. Okay, so lack of a common language needs to improve so that we have a good standardization. When we say about mince and moist, everyone will understand how mince and moist looks like. Yeah, and then lastly, standardization will ensure that individuals with dysphagia have a consistent access of the food for their own safe. Okay, I think that's all for my topic. Thank you very much.
Thank you very much for Dr. Noraida Omar for her very interesting presentation. She has explained a lot of thing about dysphagia and also about how to manage it through medical nutrition therapy, and also how texture modified diet have to be adjusted for the condition of each patient. So we've heard from Dr. Omar. Our next speaker here is an expert in food development for nutritional problem, and he's also an expert in molecular nutrition research. Let me introduce Dr. Jati Kusuma from Universitas Gadjah Mada. He is currently a lecturer in the Department of Nutrition and Health. His research focuses on functional food development with molecular nutrition approach. He pursued his master's degree in University of Nebraska-Lincoln in the US before obtaining his Ph.D. in Medical and Health Science in 2022 from Universitas Gadjah Mada. He has done extensive research on modification of local Indonesian food to increase its potential for nutritional therapy. Among his most recent project is the use of lactic acid bacteria in tempe fermentation to improve metabolic profile and the microbiome of rats induced with diabetes. Today, he will be sharing with us his expert opinion on product development specified for dysphagia as an optimization of Indonesian local food. So with that, I would like to give a warm welcome to Dr. Jati Kusuma.
Alright, Assalamualaikum warahmatullahi wabarakatuh. Good morning, I think it's still morning, ladies and gentlemen. So today I would like to share our opinions, with the title Development of Local Food for Patients with Dysphagia. And we have currently taught some great informations regarding how to develop the food for dysphagia from Dr. Aida. So actually some of my presentation's topic is almost similar with Dr. Aida. So hopefully I can be fast enough to introduce about this, and we will focus more on the development of the product. So what is dysphagia? So this is has currently explained by Dr. Aida, that this is a disorder of eating due to swallowing difficulty as a result of mechanical obstructions of or dysmotility. So we know that there are several diseases that can contribute to the development of the dysphagia, and we know that there are 3 types of the dysphagia, the locations of the dysphagia, the oral one, the esophageal one, and others. So patient with dysphagia experience discomfort at the throat and also experience regurgitations, aspiration, cough, and hiccup. And this is several diseases that associated with the dysphagia, such as stroke, dementia, Parkinson's disease, Alzheimer, etc. And okay, yeah. So what's the types of dysphagia? So actually, they are oropharyngeal and esophageal. This oropharyngeal can be caused by structures due to carcinoma or cancers, infections. There is some webs at the proximal esophageal, triomegaly, and diverticulums. Yeah. And it can also caused by neuromuscular disease. At the esophageal, it can be caused by the neuromuscular motility disease, and there are 2, the primary and the secondary, and it can also caused by the structural problems, such as there is a carcinoma, diverticula, eosinophilic esophagitis, etc. So this is the types of dysphagia that are currently explained by Dr. Aida. And it's not working. Okay, so what's the health risks of the dysphagia? When people have dysphagia conditions, around 40% of the patients with dysphagia experience undetected pneumonia because food or drink enter the lung. Yeah. And it can also cause malnutrition and dehydrations. Also, it can cause inability to take oral medications, which led to the exacerbate of the disease and lead to death. And okay, so how to manage dietary management for dysphagia? As Dr. Aida said, that we can use a texture modified diet to improve nutritional status of the patients with the dysphagia. And currently, the standard used for the dysphagia diet, it's developed by the International Dysphagia Diet Standardization Initiative, IDDSI, which replacing the old standard, the National Dysphagia Diet. So, based on this one, texture modifications is important for people with the dysphagia. But the problem is, as Dr. Aida said, the texture modified diet has a lot of leftovers. So how can we solve the problem? So there is actually currently one types of knowledge that we call molecular gastronomy. Yeah. So what's molecular gastronomy? I will explain that at the later slide. But molecular gastronomy is interesting because it can be incorporated in the development of food in dysphagia. And also, by applying molecular gastronomy, the food that we can use for treating the patients can be anything, even from the local food. So I will show you how to develop the dysphagia diet by applying the molecular gastronomy methods. Yeah, so this is the molecular gastronomy. What's molecular gastronomy? Molecular gastronomy is a technique. It's a gastronomy field of science that can transform all of these types of food into a more suitable diet based on the texture. And the rationally behind the gastronomy molecular or molecular gastronomy is by understanding the science behind the molecules itself. So when we talk about molecular gastronomy, actually we are talking about chemistry, we are talking about physics, etc. But it can be incorporated into food, so the food can be more interesting and more appealing, more beautiful, etc. So we try to introduce the new concept for the dietary management of patients with dysphagia by molecular gastronomy. Okay, next. So this is the framework of the IDDSI, as Dr. Aida explained before. So I think I just skip it, but the interesting part is if we applied the molecular gastronomy technique, actually we can modify, texture modify in the level 1, level 2, and level 3. Even for the level 4, we can also modify the food by molecular gastronomy technique. Next, please. Okay. So what's the difference between the current IDDSI with the NDD, the National Dysphagia Diet? So for the current IDDS1, next. Oh, sorry. I think I lost that one. Yeah. So can you back? Yeah. I think it should be some table over here, but I don't know why it's not presented in here. But there is the difference between the IDDSI compared with the NDD. It's actually how we can objectively measure the consistency of the drink and the liquid or the food. Yeah. For instance, I think I have one video. So next. Yeah. So the IDDSI level diets. So they are currently have 7 level of the diet, as Dr. Aida has explained before. And I think I will skip this one because you already have this informations from Dr. Aida. So next. Okay. Next. Yeah, so this is the categories, level 0 up to level 6. And how to measure the thickness of the category. We will have some video. Next one, I think. Next slide, please. Yeah. So this is the comparison test for comparing between level 1 up to level 3 of the IDDSI level diet. Okay. So can we click on the video? Oh, I see. It's not. Yeah. It's not working. I don't know why. Yeah, it's not working in this slide. Actually, so can you click over the? Okay. Yeah. So this is well. Yeah. I just want to show you that we can use a string, yeah, to measure the texture of the liquid. And next, we can just focus on the molecular gastronomy. So what's molecular gastronomy? So molecular gastronomy is a scientific discipline that explores the phenomena occurring during culinary transformations. And unlike traditional food science, the molecular gastronomy is focused on applying scientific principles to enhance understanding of the process cooking at a molecular level. And molecular gastronomy can be used to create proper consistency and texture for dysphagia patients. And molecular gastronomy utilizes several food preparation techniques such as emulsifications, spherifications, and jellifications, and these can be ensured for the consistency of the food. Yeah. So we have the emulsifications, and we get it at the basic in organic chemistry. And organic chemistry for emulsifications. Spherifications is actually we try to envelope the food component into matrix. Usually the matrix was made from calcium alginate, calcium alginate matrix. And there is jellifications. We can also make a gel to prepare our food. Yeah. And this usually we can use several techniques for jellifications, such as by using the gelling agents. And interestingly, some food in Indonesia has a gelling ability properties. So it can be used for development of the diet for people with dysphagia. Next. Yeah, so this is the types of the food that can be explored by molecular gastronomy. This is the fruits gels. As you can see in this picture, we have a strawberry fruit gels. Yeah. We can also use other type of fruits such as pomegranate or other type of fruits to make this gel. And this gel, if we look into the IDDSI consistency, yeah, it appears to be level 4. Yeah. So it's level 4, and it's require minimal or minimum chewing, yeah, compared with the others one. And also we have this. This is the foam. Yeah, we can create the foam for patients. Yeah, and we can deliver water into the patients by using this foam instead of using thick liquid or thinner liquid. We can use this type of the foam, and this can be made by molecular gastronomy. Or the next one is for the gelling. Yeah. So this is the gel made from milk. The white one is made from milk, and the red one it's from guava. So we can try to apply the molecular gastronomy, but in this one, in this example that I want to introduce to all of us, is that molecular gastronomy can be used to deliver delivery of the water component into the patients with dysphagia with minimal risk of choking. Yeah. So we don't want that for the patients with the dysphagia, but we want to minimize the risk of dehydrations of the patients by using this molecular technique. Next. Yeah, this is foams and this is spears. Next. Yeah. So how about the study? Yeah. Right now we have how about the study? Yeah, study by Kim and Ju in 2015 report that chopped, grounded, or blended food has low satisfactions and preference among elderly. So elder people do not they don't like the chopped, ground, or blended food. But when the researchers try to introduce molecular gastronomy to them, the response are very interesting. We have a very interesting result in this one, like the provisions of convenient food consumptions, proficient enjoyment in the presentations of the foods, easy mix of the ingredients, provision of foods with new texture. They have scored more than 4 at the 5 scale. So they are 5 scale. The 1 is several like they don't disagree. The level 2 is disagree. Level 3 is neutral. Level 4 is agree, and then the level 5 is strongly agree. So most of the patients in the study, they reply on average around 4.5. Yeah, so it's almost strongly agree. They feel that by using the molecular gastronomy, they have better presentations, they have better texture, and then they also have they can also improve food intake in elderly people. And next. So how can we apply Indonesian's food for the molecular gastronomy one in the developing of the diets for the dysphagia patients? So as you can see, Indonesia has lots of foods here, from fermented food up to non-fermented foods from all over the regions in Indonesia. And we can actually, we will give some examples of how we can apply some local Indonesian foods in the term of molecular gastronomy. So we will have, we will try to give some example. Next. Yeah. Okay. So I just want to ask, mungkin saya bertanya di sini, ada yang tidak kenal tempe? Ada yang tidak kenal tempe? Tiap hari makan. Yeah. All right. So the first one is the interesting part. Interesting part of the food that can be used for the molecular gastronomy one is soy tempeh. Why? Because soy tempeh, actually it has numerous biological active compound, yeah? And tempeh was considered as functional food, yeah? Due to the present not only nutrients but also bioactive compounds. Yeah. The bioactive compounds from tempeh, it's not only the isoflavones, but actually we can modify what will happen to the tempeh, yeah. What secondary metabolites that we can produce in tempeh that can be applied into the dietary managements for the patients with dysphagia. And next, here is some study, yeah, regarding the tempeh as enteral food for stroke patients. Yeah. And this is the study conducted by Sulistianingsih in 2022, reported that administrations of enteral formula from tempeh called supromin increase albumin and reduce total cholesterol level compared with commercial formula. So this indicated that tempeh is actually beneficial, has beneficial effect on the stroke patients. And another study conducted by Ismail et al., and this is with also Bususi, the Bususi study, they report that supplementations of tempeh enteral formula for 3 weeks among stroke patients, yeah, this reduced the middle upper arm circumference, lila, lingkar lengan atas, and increased BMI. Yeah. Why this happened? Because the first study was conducted at the hospitalized patients, whereas the second study conducted at the post-hospitalized patients. So these discrepancies can be explained by lack of dietary assessment, low physical activities, and they are not assessed these factors, contributing factors that may affect these two variables. Yeah. So we only found these 2 studies, so we conclude that further studies are required, although preliminary results show promising effect. Yeah. Next. Yeah. So the next one, as I suggest before, that actually tempeh is a wonderful wonderful food, yeah, because we can modify what will present in tempeh, like in this one. So we took several tempeh samples, yeah, from tempeh producers in Yogyakarta, and we clearly see in here that the microbial compositions of the tempeh is different. Yeah. So and this difference, like the bacterial compositions of tempeh is different, it can also have a significant impact on next. Okay. So what will secondary metabolites they produce? Like for this one, we can clearly see that in some tempeh, yeah, they have nucleotide metabolisms, yeah, and there is also a difference in energy metabolisms. So based on this one, they will affect the vitamin and cofactors biosynthesis, flavor, and other secondary compounds, yeah, in tempeh. So actually, if we make tempeh from different technique, it will affect the bacterial compositions, and the bacterial compositions will result on the ability of the microbial community to produce vitamins and cofactors, flavor, and other secondary compounds. Next. So we try the first our first study actually tried to enhance the isoflavone compound by supplementing the lactic acid bacteria into the tempeh productions. So we add lactic acid bacteria that express the enzymes which is important in the bioconversions of the isoflavones. If the isoflavones present in soybean actually is in the form of complex isoflavone because it has it attached with the carbohydrate compound, and it called the malonyl isoflavone compounds. And where there is an enzyme called the beta-glucosidase enzymes present in lactic acid bacteria, they can cut the carbohydrates moieties or carbohydrates structure, and they produce the high biological value isoflavone called glycan isoflavones. And this glycan isoflavone, it's actually can be used to reduce the cholesterol level, and it has an antioxidant. And interestingly, a study conducted by Azahra et al. Currently in 2023 reported that when we add some lactic acid bacteria that has the beta glucosidase activity, it can protect the mice. So this is the in vivo study, the mice from high fat and high fructose diet. So preferably then, if we want to enhance the effect of the enteral food derived from tempeh, we should consider by transforming the malonyl isoflavone into more bioactive and more stable isoflavone called glycan isoflavone. So what's our study said? Yeah. So we have currently or successfully isolated lactic acid bacteria from numerous Indonesian local food. Yeah. So this is gaplek. Ada yang tahu gaplek? Ada yang tahu gatot? Yeah. So gaplek is actually fermented cassava that can be used for the development of gatot. Ya, jadi bahan apa namanya? Bahan awalnya gatot itu gaplek, gitu ya. Ya, singkong seperti itu, singkong gaplek yang hitam-hitam, ya, yang hitam-hitam. And we have successfully isolated lactic acid bacteria from here that express the beta-glucosidase. And also this is badek. Ada yang dari Jawa Tengah? Dari daerah Borobudur ya. This is from Borobudur regions. Ada yang rumahnya sekitar Borobudur? Ya. Ada minuman yang namanya badek ya, dari nira. Nira apa ya? Saya bukan kelapa ya, tapi ya nira ya. Nah, siwalan. Oke, siwalan. We call it siwalan, bukan sialan ya. Ya, siwalan ya. Jadi we also have isolated the lactic acid bacteria from badek and found that they are also expressed. So this is our study. This is the gel electrophoresis for the beta-glucosidase genes. So we try from lactic acid isolate lactic acid bacteria from fermented cassava, and it has this big and then we also isolate the lactic acid bacteria from badak, and we also have this band. Yeah. And also there is others food with beta glucosidase activity. This is growol. Ada yang tahu dari Kulon Progo? Growol? Ya. Growol sepertinya sudah tergantikan dengan KFC. Oke. Yeah. Okay. So growol actually currently we have isolated so this is our study, current study. So we isolate lactic acid bacteria in this media, and if you look carefully, there is a black regions over here. So if the lactic acid bacteria in here produce the beta glucosidase enzyme, it will turn the media from yellowish color into a dark color. So this is indicated that some lactic acid bacteria from growol also express the beta glucosidase. And also this is from dadi, yeah, from fermented milk. Also we try to isolate the lactic acid bacteria and conducting this test, and they also express the beta glucosidase enzymes. Next. So when we apply into the tempeh, when we try to pick one isolate, lactic acid bacteria isolates, and then try to make the tempeh, as we clearly see from the table, that the lactic acid bacteria supplemented tempeh has a higher level of the lactic acid bacteria count compared with the standard or normal tempeh one. And we analyze the isoflavone contents. We clearly see a significant increase at the genistein level. Yeah. When the tempeh was developed by using supplemented with the lactic acid bacteria, the isoflavone, especially in the genistein level, is higher compared with the standard tempeh one or regular tempeh one. And this is the nutrient value of the tempeh. As we can clearly see, the interesting part about this, when we try to add the lactic acid bacteria, it not only affect the isoflavone, but also the nutrients value. The important one is this one. This is the dietary fiber content. As we can clearly see, there is a significant increase in dietary fiber content compared with the normal one. Yeah, so this is indicated that the modifications of tempeh actually can affect the nutrient as well as the bioactive activity. So next. Yeah, so this is the others. This is the our current project also. We try to develop tempeh that produce GABA, the gamma aminobutyric acids from lactic acid bacteria. And what is GABA? So this is a brief explanation. So GABA is neurotransmitter which main effect is to inhibit the neurotransmitter in the central nervous system. And GABA actually can be used for recovery, yeah, for help for brain recovery after stroke incidents. So if there is a stroke attack, and then after 2 or 3 days post-stroke attack, if we supplement the patients with the GABA, actually they may recover fast, yeah, compared with if we treat the patients at the early stage. So we need to postpone GABA treatment for 2 or 3 days after the stroke attack, because if we look into the meta-analysis and systematic review, if we give the GABA agonist just after the attack, it will cause death and also it will cause several problems. Okay, so how can we do that? How can we try to to improve the GABA. So next. Yeah, so this is quite similar with what we have done, but in this case we use the reverse transcribe PCR to detect whether the lactic acid bacteria isolate actually express the enzyme that are important for the development of the GABA. The enzymes called the GAD, glutamate dehydrogenase, if I'm not mistaken. Decarboxylations, yeah. Glutamate decarboxylations. And interestingly, we try only one food, which is from the growal, yeah. And we found from several isolate lactic acid bacteria, we found that one potential lactic acid bacteria that can be used to produce GABA. And then next, we also try to, and we try to analyze the GABA at the media, and we found this is a really surprising result, because in some fermented foods such as dadi, yeah, lactic acid bacteria can also produce GABA. But interestingly, in this one, the GABA content is almost 3 up to 5 times than the available publications available. Yeah. So right now we are still currently developing the tempeh GABA, and hopefully we can get informations regarding the GABA content also at the nutrient level. Why GABA is important? Next, because it's not only for patients with stroke, but it can also has an anti-hypertension activity. So this means the GABA in tempeh that we are currently developing can be used for the preventions of the hypertensions. And interestingly, right now we are still conducting a research for this tempeh GABA for autism. Yeah. So hopefully in the future, the autism diet, we can use this tempeh GABA for diet for people or children with autism. Yeah. Next. Okay, so last but not least, yeah. This is, do you know what is this? Ada yang pernah tahu porang? Porang? Konja? Konja. Yeah, it actually almost similar with the konjac, but this is it's different. Yeah, konjac is from Japan, yeah, and this is local. And in porang, they have a substance called glucomannan, and this glucomannan can be used as gelling agents. So when we try to develop the gastronomy molecular food, we can also try to use this one, the glucomannan porang. But the problem is it has a higher level of calcium oxalate, I think, and this calcium oxalate is a toxic, yeah, for the cells, also for our. Yeah. Next. So this is the conclusions of our presentations, that dysphagia is conditions that affect swallowing and can decrease nutritional status due to low food intake. And molecular gastronomy, yeah, this offers a new way, not only in preparing food, but also in increasing food intake with dysphagia, although more research are required to elucidate the benefits. And several local Indonesian foods can be incorporated into the diet by modifications to enhance the health promoting activity and food intake using the molecular gastronomy. So that's all for my presentation. Thank you very much. Selamat siang.
Thank you very much, Dr. Rio, for the fascinating presentation. It's really exciting to know that actually a lot of food in Indonesia can be used as an agent to, alleviate problem, especially dysphagia. So today we're going to approach the Q&A session. If anyone from the audience have a questions for both of our speakers, please raise your hand. All right, while we wait for our offline participants to ask a question, let me read a question from our online participant. Okay, the first question. I think this is for Dr. Aida. Based on your experience, dietitians should discuss with whom to determine the form of food for patients. I mean patients with difficulty swallowing or dysphagia. Dr. Aida, you can answer the question.
Thank you very much, Ibu Retno, for the question. Yeah, so referring to my lecture just now, okay, speech therapists will diagnose the issues, and then they will determine which level. Okay, so we dietitian will follow the prescription, and then after a few days, and then we can see the improvement of the food intake, and then maybe speech therapist will revise again and meet patient, and then will determine the higher levels. Okay, so meaning that the determination of which level is decided by speech therapist, not the dietitian. Yeah, thank you.
Dr. Aida, the next question is for Dr. Rio. I wonder about tofu, oncom, or other type of fermented soy. Are there any evidence about the effect of them in improving health in dysphagia or malnutrition?
Yeah. Okay. So actually, for the oncom, we know that some mold from the oncom actually can be developed into single cells proteins. Yeah. So we can extract the proteins from the mold, and then it has higher biological value of the proteins compared with the fermented soy itself. Yeah. And the interesting part about these single cells proteins, actually it has less waste. So it reduces the carbon produced. For instance, at the cows farm, cows farm, they emit gas, etc., that may affect our atmosphere. Yeah. So the protein mold, the mold protein actually can also be developed into meat synthesis. Yeah. So there is a meat synthesis developed from these mold proteins. So yes, for the oncom, we actually can extract the mold from the oncoms to develop into the protein, which called the single cells proteins. So yes. We can use, instead of tempeh, we can also use the oncom for preventing the malnutrition.
Okay, thank you, Dr. Rio, for your insight. Next, do you have any question from our offline participant here? Not yet. Okay, let me read another question from our online participant. The second question for Dr. Noraida Omar is there any research related to the level of these food forms on the food intake of patients with dysphagia?
Okay. Which level?
I think it refers to the level by
Is
DSSI.
that related to the first question? Level 4 and below?
Is there a research related?
I think so. Okay, thank you, Ibu Retno. Okay, for the first question, for the puree or lower level of consistency of food, is usually produce more food waste. Okay, from your experience, how to prevent the food waste of the food? Okay, for level 4 is a puree diet. Yeah, and then it relates to the consistency of the liquid, level 3 and until level 0. Yeah, to answer for the how to prevent the food waste for puree diet, yeah, usually they requires a lot of effort. Yeah, so puree diet is a blenderized diet. How to improve the presentation? Like I said, we eat with our eyes. Okay, so by using the mold, nozzles to make it the puree diet like a normal food, so to improve the presentation. But for level 3, 2, 1 and 0 is more towards liquid. Okay, we need to use a lot of assistance from the straw, from the string, to a lot of effort and assistance from the caregiver or healthcare professional to help patient during eating time. Okay, proper position. Okay, no need to rush. You need to give more time. So meaning that the liquid, the food needs to provide more time, small and frequent meals, so that patient able to finish it. Yeah. So yeah, it requires a lot of effort and patience. Yeah. Okay, I hope I understand that. I answered the question.
Okay, thank you very much, Dr. Aida, for the answers. Is there a question from the audience? Okay, please. Okay, thank you.
Thank you so much, Dr. Noraida and also Mas Rio for the presentation. It was very insightful, and I'm happy to get more knowledge from that. The question is, I think it's for Mas Rio. If I'm very interested in the molecular gastronomy food technique and products, and also I wonder if we change the texture for the dysphagia patients, for example, the puree one, or the another soft texture of food for dysphagia patients, will it also change the component of the molecular gastronomy food itself? I wonder. Thank you so much.
Thank you, Buwita. Actually, we can tweak or we can modify what's in there, but the molecular gastronomy actually, there are several techniques that can be used, and we can modify what's inside them. But the basic science behind them is, for instance, the encapsulations, the encapsulation procedure, and then the gelling procedure. So we must know what syneresis means, and then how to make gel, etc. So basically, if we add a compound, and we know exactly what's in there, for instance, emulsifications. We can actually use emulsifications for food with a high fat level, for instance. And it will increase the energy consumptions for the patient with the dysphagia. But the presentations and this is just some suggestions, based on the technique itself, the molecular gastronomy itself, because I tried to look into the publications or study regarding how to implement the molecular gastronomy into the patient with dysphagia, and found one study regarding that. But interestingly, they didn't give it into the patients. They just do the organoleptic test for the product, and compared with the commercial one. So most of the subject, actually, they prefer the molecular gastronomy technique to be used in patients, in diet in patients with the dysphagia, but I can't find other study than that. So it's really hard, and actually it can be developed further, or we can research more on that one, because it's a really interesting field of science that dietitians and nutritionists actually should understand and should try to improvise their appearance, food appearance by using this technique, for instance. So,
Thank you, Dr. Rio. We have another question for Dr. Aida. I think the question is, how is the doctor's experience in treating patients with dysphagia? For whom is the swallowing task performed?
Okay, thank you for the question. Yeah. Okay, we're not doing the swallowing test for every patient. Yeah, so swallowing test is not the first thing that we do. Okay, after several days being hospitalized, patient we observe during the mealtime, or patient already reported to us we have he or she have a difficulty in swallow, then we proceed with the examination. Yeah, as a dietitian, the thing that we can do is the assessment during the eating time using the eat-10 screening, or another assessment like dry swallow, and then we can see the movement. There's a lot of eating ability or drinking ability assessment that we can do. Yeah, so yeah, during that's why the importance of dietitian, and with help of the other healthcare professional in ward, to observe patient eating time so that we can tackle this issue and intervene further. Okay, thank you.
Thank you. Do I have another question? Maybe from the audience here? Okay, we have just under 3 minutes for the Q&A session. I think I'm going to ask Dr. Rio about his presentation. I was wondering about the GABA tempe. It is made with fermented, like from lactic acid bacteria, right? Yeah. Does it have like an alteration in taste because it uses lactic acid?
okay. Thank you. Actually, I just made the product, so can I? Yeah. Yeah. So this is our product. Yeah. And we can, I don't know if there is some camera. We can just try to compare it with the regular temperature.
It just look like Allegro tempe.
Yeah, and you can also try to taste it. It's not dangerous, actually.
Okay, let me
Yeah.
try just a bite. Just a small bite.
Yeah, okay.
It doesn't taste sour at all.
So we go. So it doesn't actually. This is currently over ripening. So it should be yesterday for the optimal taste and consistency and etc. It should be yesterday. And when we tried first eating this tempeh, actually I am a bit amazed because the tempeh, this one has a savory taste, sangat gurih, and it also add some sweetness in it. So in their prime time, yesterday actually 2 days of fermentations, they have sweet taste. They didn't affect the growth of the mold, which indicated that they can work together with the mold, because usually if there is some pathogenic bacteria, like the isolate is pathogenic, it will prevent the growth of the mold, the tempeh mold. So basically, when we try to develop the tempeh, it doesn't affect the growth of the mold, which indicating that this is not pathogenic bacteria. And then the second one, it did not have a bitter taste. And interestingly, it has a savory and sweet taste after 2 days of the fermentations.
Okay, so that concludes our Q&A session. Thank you very much again for Dr. Rio and Dr. Aida for being with us today. And thank you for the audience. This is the end of the first panel. We'll see you again after the coffee break.
As we continue with our programs, please join me in a round of applause to acknowledge Ms. Bianda for her exceptional moderation skills and dedication to this symposium. Thank you, Ms. Bianda, for being an integral part of this event and for elevating our discussion with our expertise. We are truly privileged to have had you on board. Ladies and gentlemen, I hope you are enjoying the vibrant discussion and engaging session of our symposium. As we continue with our programs, I would like to inform you about an exciting activity that awaits us. Shortly, we will proceed with a brief certificate presentation ceremony, where each speaker will be individually recognized and presented with their certificate of appreciation. Now, I would like to invite Dr. Aida and Mr. Yu to the stage to receive a certificate of our gratitude. And to Mrs. D. Budining Sari, Sarjana Pertanian, Magister Kesehatan, Doctor of Philosophy, to come to the stage to give the certificate. For the next agenda, we will have a photo session followed by lunch break and poster session. Please be prepared to join the guided photo session immediately following the upcoming session. Our committee members will be delighted to assist you in making this experience a memorable one. Let's start the photo session. 1, 2, 3. Ladies and gentlemen, now the attendees are welcome to take a break. We will start the next session promptly at 1 p.m. Due to the food and drink prohibition, please do not bring your food or drink inside. For offline attendees, please look up outside this auditorium where there are exhibition posters to visit. And don't forget to vote for the poster of your choice. Thank you and enjoy your break. Welcome back, ladies and gentlemen. I hope you had a pleasant break. Previously, I want to say thank you to University Putra Malaysia as a part of the co-organizer of INHESION 2023. Ladies and gentlemen, I trust you all enjoy a refreshing lunch and some well-deserved relaxation. As we gather once again, I would like to bring your attention to the next significant segment of our symposium. In just a few moments, we will be resuming our symposium with the highly anticipated second panel discussion of the symposium. With that said, it is my honor to announce that I will now be handing back the reins to our esteemed moderator, Ms. Bianda, who will expertly guide us to the remaining session of this event. Ladies and gentlemen, please welcome our moderator, Ms. Bianda Aulia.
Welcome back, ladies and gentlemen. In this session, we are going to have a very interesting speakers. In the second panel, we are going to hear from two speakers who will be joining us remotely from Sweden and from the Netherlands. Similar to the first panel, the Q&A session will take place after the second speaker finishes her talk. Before we begin, let me introduce our speaker for the second panel. Our next speaker is an associate professor from Karolinska Institute, Dr. Ioannis Ioakeimidis. His area of expertise includes the prevention of childhood overweight and obesity from such a young age. His most recent works focused on behavioral science and the development of big data and digital health for the evaluation and modification of behavior in children. We have Dr. Ioakeimidis here with us already. And as we know, the worldwide prevalence of childhood obesity is rising. And it also occurs here in Indonesia. And this upcoming talk will be very relevant as it gives an example of initiatives for tackling this problem. Dr. Ioakeimidis will talk about sustainable diet and encouraging environment in the prevention of childhood obesity and metabolic syndrome. All right, let's welcome Dr. Ioannis Ioakeimidis. Dr. Ioannis, thank you for joining
Hello.
us. Yes.
Can you hear me? Is the sound okay?
Yes. You can
Excellent.
start your talk now.
Yes. Let me share my screen. Sorry, I just need to confirm what you can see.
It's actually in
In the other mode, right?
Yeah, another mode.
Right. What can you see now? Can you see the correct thing?
Yeah,
No?
yeah, we can see it clearly.
Is it the full mode?
Yes, it's in the full mode right now.
Excellent. So, thank you very much to be here. I will talk about the sustainable diet and encouraging environment, food environment, one can say, in the prevention of childhood obesity and metabolic syndrome. I want to start this by saying who I am and why I'm here. I'm an associate professor, as you said, in the Impact Research Group here in Stockholm, Sweden. And this is a group that is led by Professor Marie Lev, and I am running my own work unit, like a separate small group. In the group, what we do is we are working a lot with digital health, a lot of mobile apps, and a lot of data collection from children and families and young mothers. We also have a clinical part. But what we are trying to do is we are trying to have the technology in the foreground in order to be able to, do data collection with breaking through the traditional and try to go to the real life and see how's the situation out there. and you will understand why I say that. I will say that my own personal interest when it comes to research, the last, I don't know, 20 years, is there are two axes. One of them is the analysis of living and food environment, analysis in our neighborhoods, in our cities, and especially with regards to and focused on children. But we are also having this other part, which is a technology-assisted individual behavioral monitoring, where we are, instead of looking at populations, we are looking at the individual. But today we will mostly be talking about the food environment analytics. And as it is, I have to I have to admit that my research has been very much focused in Europe, so I have to admit my ignorance a little bit about the situation in Southeast Asia and in general outside Europe. But our research has been driven a lot by big European projects and Swedish projects. So these names mean nothing to you. It's just kind of a history that I will try, a story I will try to say to you how we came to be interested in the food environment of children. How did we start working with children? How we got interested in the food environment of children? And why is that important? And how can we go forward with that in the future? And what type of maybe social impacts we can mediate? And this is probably something to discuss later on in the panel. But let me take you through this, and I will start from my earlier project. This is Splendid. It's a project that it had a lot of European partners. I'm not going to go into many details about all of this. It's more like a narrative. It's a story. You can check the links and the references throughout the presentation to get more information, and you can reach out to me as well, in all honesty. But what did we do in Splendid? In Splendid, we started with trying to using new sensors and technologies in order to reach out and understand how people eat their school food in Sweden, and go a little bit beyond the school grounds as well. So what you can see here is a small personalized scale. The children put their plates on it, and then we count in real life how they are eating their food. And this is quite interesting because in Sweden, all of the schools up to a certain age are obligated to offer warm food, a buffet, in a buffet setting most usually. So the students stop their school day, they have lunch at school, and then they continue with their lessons. And there is a obvious interest in the society on what is happening in the schools and how do children eat their food, because of course it connects with the rising obesity prevalence in Sweden as well as in Europe and across the globe. So this is our main interest. You can see this small scale on your left, and then we also had some prototype sensors, which is things that go in the air, and we can count the chewing sounds from the mandibular area so that we can automatically detect meals away from school at home. Of course, this is a prototype technological project, and the thing that we mostly do, and it's larger scale, is our apps. So we are doing a lot of apps, and we're getting better over the years. This is one of the first efforts we did, where we are collecting information and we're giving feedback back to the user. Today, it's mostly about how we collect the information and what we do with this information. But what I want to show you about Splendid is that in general, we had a limited amount of schools, mostly pilots within one or two schools in Sweden. And the idea was, our main interest was to study the in-meal behavior during the school lunches, as I said, in the schools. And we wanted to have an overall image of the daily eating and physical activity monitoring for students, so that we know what students are doing. This, as I said, it was a pilot project, but I need to set up a little bit the environment where we are working so that you have an idea. This is a school that is placed in central Stockholm, in the capital of Sweden. It's a school with a little bit, at the end of the school range, 15 to 19-year-old students. As I said, it's in downtown Stockholm, and the students have free access to surrounding restaurants and to food retailers. So it is this type of places. If you ever visit Stockholm as a tourist, you will go by this part of the city for sure. We are talking about the middle of the city, in effect, the middle of the Swedish capital, right? And as you can see on the right, of course, the school has a lunchroom where children are supposed to eat their food. This was our first effort in schools. We met the kids. We were young. We were very happy. It was really exciting. And what did we do? We went and we tried to model the eating behavior. So we retrofitted areas of the lunchroom, where the dining area, let's say, of the school, with these machines. You can see them on the tables. And the students, as part of their everyday life, were coming and they were having the lunches there. And I think it is nice that you can maybe see this a little bit. This is, of course, higher speed, and this is how it looks like. We have on the left side, we have the buffet. The students every day, they are taking their foods, and then we are setting up and they're coming and they are eating inside. This is nice because we are retrofitting and we are kind of getting the students in their natural environment. They're doing more or less, of course, what they're doing every day, one of things. And then we can do analytics, like we can see how quickly they eat their lunches. We can see how many times they are leaving the table to go to the buffet. You cannot see that in the graphs here. And we can do analytics that we can then kind of model and give information to the school. So what we saw is that male and female students are quite quick in order to eat their lunches. You have to think here that Swedish schools are usually having they are giving to the kids time around 15 or 20 minutes to come inside the dining area, eat, and go out. So this is quite short. And this is because of necessity. We are talking about school about 700 students, and there are only like 150 eating places, dining places. So classes have to come in, eat, and go out. But what we have said here is that this can create pressure for the students to finish the food quickly, and that's what we see. For example, you can see that the female students in average were eating around their lunch in 9 minutes, right? And this is with all the visits inside to the buffet and things like that, if you visit again. But this is the beginning. Another thing that we did, and this was a second thought, and this became kind of the main thing going forward, is that we said to the kids, okay, you can also record your meals, both at school and outside the school, with this app, taking pictures. And what we realized is that children really enjoyed taking pictures of their foods and other stuff around them. That this became a very major thing, even if for us in this project was a second thought. And we got these pictures and we started using them in different ways. Apart from actually looking what's on the plate, we also started to using the metadata of these pictures across day. And what we can see here is for a class during a week when the breakfasts happen, which is 6 to 8 o'clock in the morning before they go to school. The lunch, which is correctly at around 10 o'clock. This is when 10 to 11 to 12 o'clock is when Swedish schools are serving lunch early for Greek standards. I come from Greece originally, so it was surprising to me at that stage. I was new in Sweden as well. And then we have the dinners around 6 o'clock and so on at home. And we have snacking that's happening throughout the day and mostly after school. This is a pattern we saw continuing throughout the population, the student population. And going forward, we are quite interested to analyze this type of data where we are seeing meal distribution in different population and type of external environmental factors that can change this pattern. The pattern is, lunch in Sweden at least. Lunch is kind of early. During the weekends, it becomes a little bit later. And then we have snacking towards the second part of the day. Here, we're not talking about the quality of snacks, but I can assure you these are mostly not fruits. They are mostly, savory snacks and sweets and so on and so forth. But here comes the moment that kind of drove our research going forward. I was talking to the headmistress of the school anecdotally, just at the corridor of the school while we were there. And we were walking around the school, and what we saw is that we saw a Coca-Cola cup with a McDonald's logo on it. And then we started the discussion, and she made this statement that, and this was 2000, I don't remember, I will lie, that's 2012 maybe. And it says that as a school, they have this problem that they have to go around every day and clean Coca-Cola cups from McDonald's around the whole school. Why is that? Because the students are going to the McDonald's shop that is just outside, and they are buying their snacks and they bring them in. And this got us thinking, the creative just started flowing, and we are like, this is an issue, especially in this school that is downtown in Stockholm, and this is something that we kept in our mind. At the same time, and this is a personal experience, my son was around 4 years old, and it was the first time that when we were driving, he saw the logo of McDonald's next to, while we were driving as a family. He's like, this is McDonald's and I want to go there. We're like, you're 4 years old, we have never been to McDonald's. How do you know that this is McDonald's? What is this? How does a 4-year-old kid already know about this, right? So this was, as a parent, but also as a scientist, an important moment. We kept this in our mind, and we went to our follow-up project, Big O. More people, quite a lot of overlap, similar type of institutions across Europe. But now we had schools from Sweden, Netherlands, and Greece. And we started to look at different factors. The idea is to collect big data. Big O means big data against childhood obesity. So we wanted to do to collect a lot of environmental data on a big data scale for student population across different schools and across different countries in Europe, in order to see how do this associate maybe with the BMI of the children, and what can we do, how can we feed this to authorities. So the idea here is that we had the centralized system, the data collection analytical platform in the middle. We are getting data from schools, we are getting data a little bit from clinics as well, and we are giving data out to health scientists, to public health authorities in Sweden and other countries, and also to the clinicians and the schools themselves, to see if we can somehow start the process for mediating social change as well. So the whole idea is that we had some data from clinical populations, but a lot of data from schools, 9 to 18-year-old children. I'm not going to go in too many details. We are looking at the schools here mostly today, but I would say that we were quite successful in this. I guess we also had Ireland, which I forgot, and I'll tell you why I forgot about Ireland. We collected data from more than 5,000, close to 6,000 children, and this it was, unfortunately, without the project of finishing the last data collection year when all the technology was working, everything was ready. Then COVID-19 happened, came to Europe, and then this died down. I think that we would have a very nice data collection year when also Netherlands and Ireland, you see, we don't have that much data there. That was bad, but I still think we learned a lot of very valuable lessons from this. And but the main idea and the thing that we found out of experience was that we cannot just go to schools and ask for data. We need to work with the schools and give them data back. And how can we do this? We can create nice apps that are created together with the kids, and they are acceptable by the kids, and this takes time, takes a lot of effort. How we are going to streamline our designs and our content of the apps in order to make them easily usable by the kids. We don't tire them so that they can use it for a long time. We also had a smartwatch connected to the app, integrated inside. Of course, we can see here on the left that the kids, this is a fully anonymous thing where the kids had names like Crimson Dolphin 20. They could choose different names like that. Simple questions. And we also had some pictures because we learned our lesson from the previous project. So they were taking pictures of their foods, and we had some very simple annotation. So they were telling us if the food that they are reporting is home prepared, if it contains fruits, vegetables, and salads, if it has added sugar, and so on. different annotations for different types of food with snacks, dinners. But what you're going to notice on the left side is that we also have one circle here that says food advertisements. Because of this incident in the McDonald's in the previous project, we decided that this is of interest. We want also to have the children report what they see around them that has to do with food. We also, on the right side, you can see that it was also kind of a gamification element where the children were getting medals, you know, like if they are bronze, silver, or gold citizen scientists, and they were contributing a lot of data. We actually had physical medals by the end to give to some of the younger children who liked them a lot. But because of COVID, I still have most of these medals in my office somewhere. Or I think maybe they're in Netherlands, most of them now. Anyway, this was nice. And what can we do with this type of pictures? We can analyze the type of meal. Of course, we can analyze the timing of the meal, the place of the meal, and this is important, where did the meal take place? Because we had GPS episodic and also continuous monitoring. We also have the user information, what they told us about the meal. And of course, we can analyze the pictures as well. And in effect, at the end, we managed to collect more than 120,000 meal pictures from children of these ages, which I think is one of the biggest data sets of children-specific food pictures, maybe globally, certainly in Europe. So this was gratifying. It showed that the kids really enjoyed doing that, right? But in order to go to schools, as I said earlier, and I'm touching upon the same thing again, we have three types of actions that we were working together with the schools, with the administration of the schools, in order to make this acceptable and to make this kind of scale up. We support school projects. We are following citizen science actions and principles, where the children will kind of motivate them to make them understand that they are offering the information for the good of the society, of fellow students, and things like that. And we also were supporting school student competitions, where a class was, you know, competing against another class who's going to send more data. Maybe we had, in some cases, school against school, and even across countries. We told, you know, a school in Greece is performing really well. Can we beat that? Things like that. The school project part was interesting here because this was the beginning of what came for the main interest on the food environment, the analysis of the food environment. So one of the early on in the project, one of the teachers was like, we need to do a small school project, but we don't have time to do foods and we don't want children to take pictures of their foods. So what can we do? And we're like, how about we have the kids go to different areas in Stockholm, in different neighborhoods, also with different socioeconomic status, and try to map all the food advertising, and then the food advertising that is visible. So we had the children themselves, groups of children going to different neighborhoods across Stockholm and start taking pictures of all the advertisements that they can see. And with these two specific neighborhoods, what you can see here is from 2018 public health report, and this is an all-inclusive report. It is data for 4-year-olds that are collected by Swedish public health authorities, that they have a representation of around 98% of the population, right? So this is, we know this, there is almost no error in that because it's almost the whole population. And what we have is, on the left side, we have Östermalm. This is the high socioeconomic area, and the green lines is the prevalence of obesity in this area. These are rich families. On the other hand, we have Skärholmen, which is one of the poorer areas in Stockholm, where also the obesity prevalence is quite high. And you can see that that's why we selected these two areas as our pilot. And you can see them on a map. Östermalm is in the center of Stockholm, close to where the school is located. Skärholmen is quite a train ride south of the city. 31 students went there. One day they went to one area. The other day went to the other area, and they did 3 days of data analysis. And then they presented their data to we kind of curated quickly the data set, we gave it back to them, and they presented the data to their school class and to their schoolmates. This was really nice. But what we saw from the beginning was that there were very big differences, even in a rudimentary analysis. You could see a huge effect between the differences in school, in food advertisements in the two areas. And then what we did is that we sent researchers in the specific same areas that the kids were in order to actually map this in a scientific, more thorough way. And this took a while, but this is how it looks. You can see here on the left the high socioeconomic status area, and this is the lower one. And what we did is that we had a very, also for the children, we did the same thing. So we had a very specific way to walk around the area and map different geographical areas that are comparable in size. And we included metro exits and metro stations in both areas. And we included also a shopping area, a shopping mall in both places, so that we can try to kind of standardize the measurements. We took, and this is an old screenshot, we took the pictures and we annotate them based on place and what was presented in the advertisement. And this was, I think, around 4,000 pictures of advertisements in this area, and these are all the advertisements. And what did we find? We found that in the two areas, both in low and high SES, the food ads are approximately 1/3 of all the ads that you can see. So among the ads of IKEA, we are Sweden after all, right? So IKEA furniture, you have a lot of advertisements for food. But these are all the food ads. The question here is that how many of these are healthy or unhealthy ads? In this case, we are using the categorization ultra-processed food. And this is based mostly on the Nova classification. There is a lot of discussion to be had about the ranking of food in this type of studies. But let's assume here everything is correct. But there is a quite telling difference between the two areas. So in the low socioeconomic area, it was quite obvious to the right side. It was quite obvious that more than 70% of the pictures of the advertisements had of the food advertisements were promoting unhealthy foods or ultra-processed foods. On the other hand, in the high socioeconomic areas, more than 60 or close to 60% of the pictures were for ultra-processed foods. That is lower than the low SES area, but by no means insignificant, right? It's still a very, very high percentage of food advertisements promoting unhealthy food. And this is somewhat common sense, and studies like that have happened previously. This was a new methodology, and we used children initially to do this, and it has never been done in Sweden before. So the nice thing is that this type of research became an article that it was quite highly quoted here in Sweden mainly. It got a lot of traction because it kind of, the interest of the public health authorities was picked, and it kind of put the problem in the correct perspective, and we put it simple numbers to it, so people started paying attention. And this led to also more resources being available to continue efforts in this area. And what you can see here on the pyramids, and you will see these pyramids again, we love them, is that on one side is the pyramid, the official pyramid of what the National Health Authority in Sweden wants or promotes as correct diet, the food pyramid, where we have mainly fruits, vegetables, and fibers that are supposed to be the majority of the diet of the population. And then we have the fish and the white meats, and then we are going to pastries and sweets a little bit up on top. But in reality, this is the type, on the left side, it is the type of the food pyramid that the advertisements are promoting, right? A lot of ultra-processed foods and fast foods, and then maybe a little bit of healthy foods on top. And this was the initiation, but Big O had another thing. I talked to you about this GPS. So this is when in the initial session of Big O, we sent children to areas that we selected ourselves. But we also had the ability to start collecting food advertisements and other behavioral and environmental characteristics reported by the kids, by the children, who could start collecting them as they encounter in real life. So what you can see here is a map divided in geohashes, small components of the map, and these are areas where the kids are reporting visits to different food places. This is the school, and what you can see here, are the ones with the non-green colors and the red ones are the worst, is that they are leaving the school, they are going to the right side, they go to the shops, to the food retailers that are just around the corner, and they are visiting them quite a lot. And then we started thinking about this concept of the micro-living environment, that a city and an area might be more or less healthy and promote healthy food, but it doesn't really make sense to look at it as a whole area, but might be better to start looking at the places where the kids are actually congregating, where the kids are. So instead of, maybe it's a good idea, instead of trying to understand what is the to categorize the whole area, the whole central, let's say, island of Stockholm, maybe we should be looking only at the streets that the kids are actually present in their everyday life. That will save us resources, and it will also be more relevant to children's living environment as well, right? So this was the continuation. This idea caught traction, and we have two national Swedish projects going forward. The AdSave, which is still ongoing, and we're working with schools as we speak, and the UNIFIT project together with UNICEF and Yerluk Fonden, one of the national Swedish funders here, that were interested in this idea of the microstructure, microenvironment analytics for children. A new ad, a little bit more simple, a little bit more acceptable to children. And this led to a nice report that was highly publicized. And here we can speak about why this is important. You understand that the wild trends in body mass index are I'm sorry, can I interrupt a little bit? And do I only have 3 minutes left? Is this true? Can someone comment on that? Sorry, no. Okay. Can the moderator talk to me a little bit?
Yes, Dr. Ioakeimidis.
Do I have only 3 minutes left?
Yes,
because I'm getting some.
Left. You can finish your presentation.
All right. So I'm going to go through this quickly. These are well-known data. Globally, the number of children and adolescents with obesity is globally increasing. This is the case in Sweden as well, that you can see a marked 400 increase in childhood obesity between the 90s and our times. And if we look at the report that we already talked about, this is unequal. There are areas with higher childhood obesity, and these are the ones we talked about. But what causes obesity? First of all, our food environment has changed, right? And there are these global drivers of a global, local drivers of a global phenomenon, where our global populations have reached a state where we are all having too much food and too little physical activity, and this brings up our total body weight up. I'm not going to go through this now because of time, but these are events in Swedish history the last 40 years that have potentially driven the rising prevalence of obesity in the society. I'm going to jump through some of the data here. And what I want to show you here is that from data of the national authority, soda drink consumption has gone up by more than 300%, and close to 400%, the snacking has gone up in Sweden, since the 60s. And I am going to go through this, and I apologize, I thought I had a little bit more time. But what we did is that we went to 2 cities, and we did what I talked to you about this thing about we are looking the microenvironment or hotspots for the children. So I'm jamming through a lot of information. We used our app, and what we said to the kids is that we want pictures of different stuff in their area, from storefronts to menus to vending machines, branded objects in their environment, anything that displays anything that has to do with food. We collect a lot of pictures, and then we can see the specific areas in cities where the kids are. And this we did in 2 cities, in previously Gävle, here Stockholm, and we can see different areas of the cities. And we can see that these areas are close to stores next to the schools and close to shopping centers where the students like to go. And it's the same story, more or less, in both cities. And then we were the scientists in these small areas, and we mapped them as well. We collected a lot of pictures. We categorized fast foods in a certain way. We categorized sugary drinks in a certain way, sodas and so on. We also had a special category for for artificially sweetened beverages. We had alcoholic beverages as well, and energy drinks. We're interested in that. And all of these together, we call them ultra-processed foods. Why do we do this? Because these are a category that in general is accepted to represent quite well unhealthy foods in our society. We did the same thing with fruits, berries, and vegetables, and fish and seafood. We put them all in the same category. And then if we look at them, what we can see that in general, throughout all the areas, ultra-processed foods are close to 80% of the food advertising where the kids are actually, where the children actually are. And this is the case, exactly the same case across the 2 cities, but it's also the case across different SES areas. So previously I said that the SES areas are different, now I'm saying they are the same. Why? Because the food advertising landscape, we believe, where the kids actually hang out in their real lives, is the same in all this, in both these areas. What we can see is that fruits and berries and vegetables are a very low prevalence when it comes to food advertising in all these areas. And it's the same thing across the cities and across the different neighborhoods. And another interesting thing is that we analyzed all the food offers, buy, pay to get 3 type of offers. And what we saw is that around 24% of all the advertisements for food are special offers. And out of this, 74% promote even more ultra-processed foods. And here we talk to the kids. I'm not going to go through this. We don't have enough time. But I will read you one because I think one of the kids said you buy candies because it's like offer. You can be in a good mood for a bag of chips sometimes. And if there is a 2 for €5 or 49 seconds treats or whatever, then you have to buy 2 instead of 1. So you save money. That was the logic of the kids, right? Children have a preference for ultra-processed foods. Healthy food in Sweden is accessible, but it's not as attractive for them, and I'm not going to go through this. But the students themselves have some thoughts on how to improve their own food environment. They are talking about potential regulations in the food offers and in the food advertising prevalence across schools and so on. And I'm not going to go through this. And I will finish with what I told you before. The National Food Authority in Sweden says that we need to eat more vegetables and fruits, eat more seafood, switch to whole grain foods, and eat less red and processed meat and less salty food. Also less sugar. And this is the type of, unfortunately, though, that this is not the case. The type of food pyramid that our food environment is promoting is exactly the opposite than the one that experts say. What is the future? The future is we need to start looking at food advertising on the digital world and social media as well, and we're doing that. But we also have to have better techniques to do this easier, that we can automatically recognize. And that was my thank you. I don't know if you can still hear me well.
Sorry. Have you finished your presentation, Doctor? Hello? Can you hear me okay? Dr. Ioakeimidis?
Yes, I was about done. It was the last email to say thank you.
Okay, thank you very much for your presentation. Please stay
All
with
right.
us for the Q&A session after the second lecture.
Absolutely.
All right. Our next speaker is Dr. Ellen Kampman. She is a professor in nutrition and disease at the Wageningen University and Research. Her area of expertise is the role of diet and lifestyle in cancer prevention and prognosis. As we know, the prevalence of Western type of cancer is also rising here in Indonesia. So today, Professor Kampman will share her insight about nutrition-related lifestyle changes.
Recording in
cancer
progress.
patients. Without further ado, I'd like to welcome Professor Ellen Kampman. Is Professor Kampman already with us?
I'm here.
Okay, thank you. Professor Kampman, you can start your presentation now.
Okay. Let's see. Do you see it?
Yes, we can see it. Could you please share it?
I can't see you anymore, but do you see me?
No, but you can share your screen to the full presentation mode, please.
Oh, I think I did.
Yes, we can see you and also your presentation.
Is it full mode now?
Not yet, Dr. Kampman. Professor Kampman.
It is in here, but I don't know. You see it now?
Yes, it's already in full mode. You can start your presentation.
Okay, so you can see me?
Yes, we can also see you. Okay.
But I guess you're there. So, good morning, everyone. Good afternoon. Salamat siang. I hope I pronounced that well. Thank you very much, organizing committee, for asking me to talk. It's of course very different from the previous presenter, but there's certainly also some overlaps. My name is Ellen Kampman. I'm from Wageningen, the Netherlands. As you can see, the Netherlands is quite far away, a very small country. Some people might know it from Amsterdam, but Amsterdam is certainly a different part in the Netherlands. That's what we always like to think. We are in the east part of the Netherlands, very different. Although it's such a small country, it is very different. Wageningen is a very small university town. This is what it looks like. We have about 40,000 inhabitants, so a very small city, and it's dominated by the university. That's why it's also called Wageningen City of Life Sciences. This is our campus, and this is our building, and these are the people of the Division of Human Nutrition and Health. We are with about 300 people, and if you look closely, you can also see that there are some people from Indonesia. You might recognize some. I don't know if they're from your university. We are split up in 5 different sections, 5 different chair groups, and I'm sharing, that's me, I'm sharing the chair in nutrition and disease. What I would like to do today is talk with you about, first of all, about cancer epidemiology and differences between West and East, with the example of Indonesia and the Netherlands. Then I would like to go into lifestyle and cancer risk, what is known and what is still missing. Then I go on nutrition during and after cancer treatment. So what do we do for cancer patients? What is known, what is missing? Lifestyle changes for cancer patients. And then I would like to end with our ongoing research in Wageningen, and maybe this also brings us to some potential collaborations that we might be able to start if you would like that. And I have some take-home messages at the very end. I guess you will put your questions in the chat. I guess so. Yeah. Okay. So let's start. So here are some summary statistics that were kindly provided to me by Ioannis, comparing Indonesia with the Netherlands. And it's interesting, the Netherlands, of course, is a very small country, as you can see. So we are about 16 times as small as Indonesia. But the number of cancer patients are just only 3 times as high in Indonesia. So it means that the incidence in the Netherlands is far higher still. And you can also see that the risk of developing cancer before the age of 75 in Indonesia is half from the risk in the Netherlands. So it's still a lot smaller. But the number of cancer deaths in Indonesia is higher than it is in the Netherlands. So there are not that many cases, but the survival rates are far smaller. And you can also see that the risk of dying before the age of 75 in Indonesia is higher than it is in the Netherlands. What is also interesting is that the types of cancer are different. So in Indonesia, the first one, the most prevalent one, the most occurring one is breast cancer, then it's cervical cancer, then it's lung cancer, colorectal cancer, men and women, and then it's liver cancer. And in the Netherlands, the most prevalent one is colorectal cancer together with breast cancer and prostate cancer. Prostate cancer doesn't seem to be happening in Indonesia yet. And then it's lung cancer and melanoma of the skin. But what we also see is a very steep rise in the incidence in the world still, but that rise is steepest in low middle income countries. So more developed countries have a rather flat line, although it's still increasing, but in less developed countries it seems to be raising far more prominent. And this might, of course, have different reasons. Of course, first of all, economic progress, which changes many things, of course. It changes and it gives an increase in life expectancy, and cancer takes years to develop. So the older you get, the higher your risk of cancer. So if your age of the population is changing towards an elderly population, there will be more cancer as well. Of course, an increase in awareness. People are going to the doctor because they feel something, they're more aware of it. And because of screening practices, for instance, for breast cancer, you will also see high rates. And also the number and the quality of cancer registries is changing all over the world, and therefore we also register more cancers. But we also see a steep increase in overweight, as the previous speaker also showed, and we see changes in lifestyle all over the globe, but especially in less developed countries. And what we also see, interestingly, is that the types of cancers in low middle income countries are changing. We see that breast cancer and colorectal cancer are increasing in low middle income countries, while cervical cancer and liver cancer are decreasing. Now, breast cancer and colorectal cancer are known to be associated with overweight, with lifestyle, and breast cancer also with reproductive and hormonal factors, like the age at which you get your first child, the number of children that you get, and also whether you're breastfeeding or not. Now, cervical cancer and liver cancer are most of the time due to infections and also for liver cancer by toxins, which are becoming less prevalent, fortunately. Now, this transition to sedentary lifestyle is happening all over the world. We know that this is happening. It's very difficult to stop, it seems. Transition to unhealthy Western dietary habits, not only the liking for these products, but also the availability, as we just heard, it's all over the place, and that's definitely changing our dietary habits. So what is now known about lifestyle and especially diet and cancer risk? We know this from the systematic literature reviews which are conducted by the World Cancer Research Fund and the American Institute for Cancer Research. And every 10 years, they will publish a report of all the literature which has been published to date. And for instance, in the last one, it included more than 20,000 observational epidemiological studies, experimental animal studies, and a few human intervention studies, as those are not conducted very much, as you can imagine. But these 20,000 observational epidemiological studies were also meta-analyzed, if possible, and using the data, using those combined relative risks that come out of these studies, they came up also with this conclusion. About 1/3 of all frequently occurring cancers could be avoided by healthy food habits and an increase in physical activity. So that's really very impressive, 1/3. And that does not mean that that's true for all cancers. It's for all frequently occurring cancers, so for breast cancer, colorectal cancer, and also for prostate cancer. The evidence and the conclusions are certainly different for different types of cancer. And here you see that they also write reports about specific cancer. This one is on colorectal cancer. You can find these on the internet, and they update them very frequently. This is the last one from 2018, but I'm sure the next one is already coming in again. And it means that they are really up to date. And they publish in these booklets, they publish the latest findings. And here you see an overall table where they show what is really strong evidence, what is really convincing or probable. And here you see for colorectal cancer, the risk decreases when you have higher physical activity, when you eat whole grains, foods containing dietary fiber, dairy products, and calcium supplements. Well, the risk is increased with a high processed meat intake, with alcohol intake, with a high body fatness, and adult attained height. So Dutch are not in a very good position because of our height. Not mine, but the rest of the population. And red meat is increasing the risk, somewhat less strong than processed meat, but still it's strong evidence for that. The rest is limited evidence. So there are either not enough studies, or the associations that they observe are not strong enough, or there are no biological mechanisms to support it. For breast cancer, and there are of course different types of breast cancer, also different findings occur. So this is the report of 2018. And here you see the increased risk for postmenopausal breast cancer is due to alcohol, body fatness, adult weight gain, and height, and decreased risk with physical activity, body fatness in young adulthood that might have to do something with their hormonal pattern, and lactation. If we look at premenopausal breast cancer, which is more frequently occurring in low middle income countries, you see that the risk is increased with height, and it is includes alcohol and a greater birth weight, but the risk is decreased again with physical activity, of course, but also with body fatness in general. So that's really interesting. That's different from postmenopausal breast cancer. So how much can we prevent? So as I said, it also depends on the type of cancer. For colorectal cancer, we could prevent half if we would stay at a healthy weight. We would move more if we would eat more fiber-rich foods, limit red meat and processed meat, and didn't drink alcohol. And we could prevent about 1/3 if we would stay a healthy weight throughout our lives. Postmenopausal breast cancer, move more, do not drink alcohol, and breastfeed your baby. It's also depending, of course, on the country and the population. These are what we call attributable risks, and these depend on the prevalence of the factor we're looking at. So if there's a low alcohol intake in a specific country, you can also not prevent that much by reducing that alcohol intake. So it really depends also on the habits of a particular population. Now, based on all the evidence, there are guidelines, just like the national dietary guidelines, and they also look very similar. So be a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruits, and beans, limit the consumption of fast foods. And here they mainly think of foods high in fat, starches, and sugar, because that increases our overweight. Limit the consumption of red processed meat, limit the consumption of sugar sweetened drinks. It's nothing to do with the sugar, but also with the overweight. Limit alcohol consumption. Do not use supplements. I don't think that's a real habit in Indonesia. If it is, then don't. For cancer risk, it's not preferable. For mothers, breastfeed your baby if you can. Oh, going back to the supplements, I think it's important to say that especially holds this increased risk for cancer if there are no deficiencies. So if there are deficiencies, it's of course good to enrich diet, to take supplements. But in a country as the Netherlands, we tend to have no deficiency. And then the intake of supplements might go over a certain limit, which increases the risk of cancer. So what is missing, in my opinion, and not only my opinion, luckily, I think everybody now knows and is aware of the fact that there is no evidence globally. So it's called a global report, but there's hardly any evidence from low middle income countries. There are just not enough studies, and we need to do that. There's hardly any evidence on rare cancer, which is logical because the numbers are far too small to do good research. For childhood cancer, for instance, we don't know the risk factors, and we don't know whether that's related to diet, although we begin to know that it might be related to deficiencies in the mother, especially for folate, folic acid. Then non-Hodgkin lymphoma, thyroid cancer, those are types of cancer that we know nothing about as far as risk factors go. And so the question also is do we have the same recommendations? Are they also applicable to low middle income countries and relatively rare cancers? And we need more evidence on exposures that we're not exposed to for a very long time yet. So new exposures like the ultra-processed foods. There have been some studies published already that it increases your risk of cancer, but also as the previous speaker said, it might not be that we are dealing with the analysis in the right way, that we don't classify these foods in the right way. We have to look into that, whether that's really true, and whether that's independent of being obese or overweight. Then in the Western world, but also I think you should be especially aware of the low but chronic exposure to toxins and heavy metals, which is not decreasing but also increasing everywhere in the world. And I'm sort of afraid that that might also increase our cancer risk, but I'm not sure yet, and we have to look into that. So what's also missing, and that's an important thing I want to discuss now, is that what should we recommend to those who already have cancer or had cancer? What should we recommend during and after treatment to reduce side effects, complaints, toxicities, and increase their prognosis? Now, when you look at the number of and mainly observational studies on lifestyle and cancer risk, you see that there are a lot of studies, more than 20,000 on risk. But when you look at before and during treatment or after treatment, you see that there are just far less studies, and also the quality of these studies are not good enough yet. We conducted some recent literature reviews together with the World Cancer Research Fund and the American Institute of Cancer Research. I was in the expert panel, so combining all the data that was produced and looking at the evidence and seeing what's here. We focused on 3 topics on lifestyle and breast cancer prognosis. They're published in the International Journal of Cancer, and this is what we see. So this is the one paper was on post-diagnosis recreational physical activity. One was on dietary factors and supplement use after breast cancer diagnosis. And the third one was about body fatness, weight change, and breast cancer prognosis. And the overall conclusion was that we definitely need more well-designed observational studies and intervention trials in diverse populations to elucidate the impact of physical activity, diet, and body composition and their changes on breast cancer outcomes, because there's just not enough evidence to really have strong conclusions and to provide really good recommendations based on the literature. But for now, there are definitely some guidelines already formulated, for instance, by the American Cancer Society for cancer survivors. And they recommend that you should begin with nutritional assessment and counseling as quickly as possible after diagnosis. That for the long-term health and increase of the likelihood of survival, you should avoid obesity and maintain increased muscle mass. You should have regular physical activity and a healthy eating pattern. And when they think of a healthy eating pattern, they go back to the cancer prevention guidelines. And also in the cancer prevention guidelines, there's also one extra item which says, after cancer diagnosis, follow our recommendations if you can. And that's the problem, because can people indeed follow these recommendations? Is that possible because of their illness, because of their treatment, because of their complaints? So this is what we're looking into. We do see, and in several papers you find that when people are able to adhere to the cancer prevention recommendations, then they have an improved survival and an improved quality of life. And we see that in older female cancer survivors, and we see that for quality of life in colorectal cancer survivors, and also for colorectal cancer survivors. So if people are indeed able to adhere to really stick to a healthy diet and a high physical activity and do not have overweight, they do better. But of course, also here, what makes this research also quite challenging is the fact that we're not talking about one type of cancer. We're not talking about one cancer patient. So it definitely depends on whether people still have a future ahead of them. So if there's a good chance of curation, or whether we're talking about people who do not have a future and are going into palliative care in the last months of their treatment. And of course, you will advise them something completely different. So it depends also on the type of tumor, the stage of the disease that they are diagnosed with, the treatment, whether they have chemotherapy, radiotherapy, or only surgery, the symptoms that they have, deficiencies that they might have, and of course, what is really important is what the patient wants and what the patient needs. So I got this from Yanni as well. I can't read it, so I hope I interpret this well. But what I thought it says is that when you look at the stage of cancer, when it's diagnosed in Indonesia, you see that about 40% is in stage 4, so in a really late stage of disease, which means that they may get a palliative treatment and may not live that very long. So that really makes a difference, and in the Netherlands it's completely the other way around. People come in at an earlier stage, also because we have a small country, it's easier to screen, and we get people in at an early stage, which makes it more easy to deal with them in a curative way. And also, maybe because it's so small and our infrastructure is, of course, very different, it's also easier for them to come to a good hospital. That also makes a difference. So, but when life expectancy is low, and we leave that usually not to our dietitians and not to nutrition scientists, because most of the time we know what is necessary. So late stage of disease and also specific tumors with a bad prognosis, like liver, lung, and pancreatic cancer. People might have severe nutritional deficiencies because of the disease. They might have unintentional, but also uncontrollable weight loss. They might have severe muscle loss, cachexia, and they might have problems with eating. For instance, people with head and neck cancer, esophageal cancer, stomach cancer, and somebody today is also going to talk about dysphagia and sinusitis, which makes it really hard to swallow and to get anything in. So that's why I also say it's also depending on what is possible. And what we tend to say very bluntly with palliatively cared person, to say, okay, just eat whatever is enjoyable, whatever you still like, but you're dying anyway. That's the fact, and nutrition is not going to help that. Then, when life expectancy is high, and that's for the early stages of disease, but also for breast cancer, colorectal cancer, prostate cancer, those cancers which are mainly associated with lifestyle, and we see good prognosis. We see that most people get cured. And we see that we have to think of completely different things here. We're not going to look so much at deficiencies, but we see a high prevalence of overweight and an unhealthy diet. Might still have deficiencies, but in a different way. We see a lot of complications, though. So these people survive, but they might not have the same quality of life because of their treatment and because of the fact that they had cancer. So we see complications with surgery. We see all kinds of complaints after or during chemotherapy. Also osteoporosis in the long term, and neuropathy in the short term. And we see, and that's a major complaint that most people have who have nutritional cancer. 40% report severe fatigue. It might be due to mental problems, but also to unfavorable changes in body composition. I'll get back to that. And we know that they have a very high risk of metabolic syndrome and cardiometabolic disease, so far higher than the normal or the general population who did not get cancer yet. We see that high risk, and of course they might still have a high risk of recurrence. Our team, our nutrition and cancer team within nutrition and disease is focusing on several problems, and the names of the people who are given are the senior associates that are working with us on these teams. The rest are the Ph.D. students and postdocs that are conducting research. So what we're focusing on is mainly on colorectal cancer, because that's the one which is related to diet. And we're focusing, for instance, on dietary fiber, body composition, coffee. And I also want to say that we focus somewhat on folate, folic acid for recurrence of colorectal cancer, but also for childhood cancer. So that's also an important topic. But for now, I focus on these three. And we are conducting an observational study, prospective cohort study, where we include colorectal cancer patients, about 2,500 we now have, who are diagnosed with colorectal cancer. And we include them in the study. We follow them up in time. We ask them to fill out food frequency questionnaires, to give blood samples, to give fecal samples. And we follow them up after 5 and 10 years, and we link their records to the population registry and to medical records so that we know whether they survived or not, or whether they have complaints or all kinds of complications. So this study has been ongoing now for more than 10 years, and we have data that I think is really interesting, especially about fiber, for instance. We looked at that in a smaller population, and we assessed with the food frequency questionnaire their dietary fiber intake, and that's before diagnosis. We asked them at diagnosis about their usual habits before complaints or before diagnosis. And as you can see, their intake is relatively low. We recommend about 30 to 40 grams per day in the Netherlands, and they are around 20 grams per day, and that's about similar to the general population in the Netherlands, although they're somewhat higher. And we looked at postoperative outcomes, any complications or surgical complications. And this is what we see. This is the colon study in general. So they are about 65, 66 years. There is more men than women. They're somewhat overweight. Most of them have colon cancer. They're not so much current smokers anymore. Dietary fiber is low, and 9% adhere to the recommendations of dietary fiber. And here you see the results. Just focus on the 0.75 and 0.676. That means that around 25% of complications could be prevented if they would have a higher dietary fiber intake before surgery. So that is what we are focusing on now. So this is the work of the Ph.D. candidate. He's studying underlying mechanisms, looking at the fecal samples, looking at microbiota, and he's also trying to do a feasibility study for prehabilitation to see if people are able to increase their dietary fiber intake before surgery. Also, we're looking at nutrition during and after treatment. We're looking at body composition. And as we know, there's a higher metabolic dysregulation with when the tumor is still in our system. We have higher protein turnover, and you see this really severe loss of muscle mass, loss of quality also. And while fat mass may remain constant or increases. And it's not always visible from the outside how much fat is in the inside or how much muscle is in there. So these men have about the same inside, but the outside is very different because the sumo wrestlers trained on that. But the sumo wrestlers do not have diabetes. They have very lean inside, so no fat surrounding the tissue, and of course a very high quality of muscle. How can we look at that? We use CT scans. So here you see such a CT scan. It's done at about the L3, and we can take this slide and color it. So you can see the subcutaneous fat on the outside. The muscle is the red. The green is the fat infiltration in the muscle. That's a really important one. And the visceral fat, which is also important. Now, this is someone before treatment with a normal BMI. And this is the same person after treatment. And the BMI still really good, but you can see that the inside changed a lot. And you see especially also the fat infiltration in the muscle, which might give enormous complaints, and also the visceral fat might increase inflammation and might increase risk of recurrence. Now, what we saw was that the low muscle density, so fat infiltration in the muscle, was extremely importantly associated with fatigue. 6 months after diagnosis and 2 years after diagnosis. So it also remains. So that's why we thought we have to do something about this low muscle density. And we also saw in the same colon study that it was related to a healthy lifestyle. So we also saw, of course, and this is what you always see when you're thinking about healthy muscles, you think about a healthy diet, but also at the same time, a healthy physical activity. So, and that's a challenge, of course, because we usually, dietitians say we need a diet rich in protein, but mind you, it should not be energy rich, because most people, at least in the Western countries, have a high body fat percentage. And this may also happen in Indonesia. So we are thinking now, what kind of protein, should it be animal-based or vegetable-based, and what kind of amino acids, and when should we provide diet high in protein, before, during, or after the treatment. So this is work in progress. What is also in progress is an intervention study that we started. This is the first intervention study that we are now doing in cancer patients, randomized controlled trials called the SOFIT study, where we screen people on fatigue. So these people really have severe fatigue, 184, and we give them a lifestyle coach, an individual lifestyle coach who comes to their homes and provide them with a personalized advice. So we have an intervention group and what we call waiting list control group. These people will also get a coach after the study is finished, because otherwise it would be fair and also not ethical. But we also have to compare them, so we give them an opportunity after the study, and we measure fatigue at the end. Yeah.
Prophet, I'm sorry to interrupt, but the time is already over.
Oh, okay.
Okay, so
I have 2 slides more, hopefully.
yeah, but right now we are going to open a Q&A session with the speakers from the second panel.
Okay.
So please wait. I will ask the audience to ask for a question if they have any. Stay with us, okay?
Yeah, that's fine. I'll just go to the.
Thank you very much for the presentation.
Take-home messages. Thank you.
Okay, I will open the Q&A session now. Is anyone from the audience have a question for both our speakers today? If you want to ask in Indonesian, it's okay, and we will translate it for you. Okay, we have a question from Buita.
Check. Okay, good morning, good afternoon. Do you see me? Okay, can you hear us, Mr. Ioakeimidis, and also Prof. Kampman? I have 2 questions for both of you. One is for Ioakeimidis, and what is the urgency and the outcome for analyzing the bite size of the meal? Because I see something in your presentations, and I wonder what is the urgency and also the outcome for that. And also the second.
Sorry, can you repeat? Urgency, you said?
Yes, the urgency and also the outcome. Okay, and second is for Prof. Kampman. Good morning, Prof.
Good morning.
Yeah, so I think the recommendation for cancer in Indonesia, also the Netherlands, is quite similar, and maybe the difference is because our choice of foods are different. And I wonder uh, how is the red meat consumption in the Netherlands, especially because I think their sustainable diets are very popular there. Thank you.
Dr.
Who do you want to start first? Ioannis?
Dr. Ioakeimidis, you can first answer the
Yeah.
question.
Right. Well, studying bites, this was a peripheral interest in this presentation, but it has been a big part of my scientific career earlier on. So the idea, this comes into the domain of research called microstructural meal analytics, and actually from Wageningen University, they have a very active research on that as well, and I have worked with Wageningen a lot on that. The thing is that the idea of going into more specific and more components of human behavior, breaking it down, that is going to help in theory in the future to, in the lab it's already done for many years, since 80s, but I mean, since the 70s, start with 80s, but what we do in the lab is that you are looking at different types of food and how they can affect critical key behaviors with regards to the meal consumption, if you look the meal as one unit. So like the bite size is a good modeler sometimes for speed of feeding, how quickly you are finishing the food. And speed of feeding itself, it is one of these factors that it has been described, and I do believe that it is. There's quite strong evidence about that this is an important behavioral factor for predicting and also describing a little bit eating behavior and obesity going forward. But the greater challenge here and the urgency, if you like, is that if we can do this in real life, it is one thing to be able to do this in laboratory conditions where you bring people in, but if you can go to schools and you do it, and that then is more interesting. And it is interesting also from another perspective. It is interesting from that it is a nice, you can create a nice feedback behavioral loop where you are giving to the user in real time, you are giving feedback as to the speed of eating with regards to how many bites they have taken. There is a lot of effort now to do this automatically where you have video, and the video, there is algorithms behind analyzing the speed of eating through bite counting in order to be able to kind of say to the user, let's say a green light goes on, you are eating quickly or you're taking too many bites. Of course, this is a little bit generalization of the domain and the field, but I would say that this is where it is. What else? I don't know. We can go on forever. We can discuss this in depth if you like, but I hope this covers your question for now.
Thank you very much, Dr. Ioakeimidis. Now, Professor Kampman, you can answer the question.
Well, thank you for the question. You asked about red meat consumption in the Netherlands, and of course it's different from Indonesia. That's also for all food. But the recommendation for red meat is about 300 to 500 grams a week maximum. And in the Netherlands, we're still above that in general. We are indeed working on a sustainable diet, but that's the interest for sustainable diets or more plant-based diet is mainly with those who have high education, a high income, so the high socioeconomic groups, but for the low socioeconomic groups, there's a huge difference. And there's also in the Netherlands a huge difference in the health of the population related to their income and their education. So that's also something we need to work on specifically, because it's really not true for all our inhabitants. Is that an answer to your question?
Okay,
Thank you so
very
much. Thank you.
We have just under 5 minutes left. We'll read one question or two from the online participants. So the first question is for Ioannis. How was the compliance of the participants in Splendid app? Because it may give burden to the children to always taking picture and report their meals every day. Dr.
Yeah, this should I answer?
Yes, you can answer the question.
Right. This is a critical question, a good one. We always get that. And it is different things. In the Splendid app, when it comes to that, it was pretty good because the app was supposed to be used in small projects for week, 2 weeks. So the children knew how to do it. They were, actively guided by the teachers and ourselves. So then the compliance is good. A better question is how was in the Bigo app, which was supposed to be used a little bit more freely in order to collect big data. And then this also connects to the second question that I see on the screen. And there it is, the idea there is that you need to find this golden balance where it is not a burden and it is rewarding enough and not very difficult so that you can collect some data over longer periods of time. This works maybe works. There is a lot of error and we should be careful with that, how we interpret this. But the idea is that if you collect from enough people for a long period of time, you will be able to potentially describe a population, but not the individual. This is not good enough in order to go to an individual and see changes in time. It's mostly in order to describe a population, taking into consideration the errors. So that would be the answer, I believe, in this. I hope it covers the question.
Okay, thank you, Dr. Ioakeimidis, for your insight. The next question may be for Professor Kampman. In your research, you show that dietary fiber consumption is very low in the Netherlands, and you show that there is a low compliance of dietary fiber diet in the Netherlands. Do you have any suggestion on how to, increase the intake of fiber, soluble fiber, especially in the diet? Thank you.
Yeah, it's really difficult. We find it's really difficult to get people to eat more vegetables and fruit, and that's partly also because it's quite expensive, and that's one thing. Secondly, it's the unhealthy foods are more available. That's also what Dr. Ioannis already told us. It's really difficult to get good quality vegetables and fruit, but also they choose for the non-fiber varieties in their flour, etc., because they tend to like that more. And so it's not my field of research, but what we are trying to do at least is to give them an app and to show them what they are exactly eating and what they should be eating, and maybe help them to change that by giving them examples of foods that are close to what they already eat, but then somewhat healthier. So, and with containing somewhat more fiber, so that we're trying to seduce them to have a higher fiber intake. But we do that together with social sciences and also the group that Ioannis was referring to. They have far more insight in how to change behavior, but it's really a challenge, I find.
Very much, Professor Kampman. So that concludes our Q&A session. I am very sorry for the limited time, but thank you for being here. And that's the end of our second panel. Thank you.
Thank you.
Thank you very much.
Thank you very much for listening. Sorry to be later, but I didn't see it. I'm sorry.
Same
Okay.
for me. Sorry for the time confusion there.
Okay. Bye-bye. Have a very good day.
Okay, say goodbye to Professor Kampman and Dr. Ioakeimidis.
Bye-bye.
So for the next session, I give back the time to the MC.
Ladies and gentlemen, we have come to the end of this enlightening and informative symposium. I hope you all have enjoyed and benefit from the presentation and discussion of our distinguished speakers. I would like to thank our speakers once again and Ms. Bianda as our moderator today on behalf of the organizing committee. I extend our heartfelt gratitude for your outstanding contribution. Shortly, we will proceed with a brief certificate presentation ceremony, where each speaker will be individually recognized and presented with their certificate of appreciation. Now, I would like to invite Prof. Allen and Ioannis at the Zoom meeting to receive the certificate of our gratitude. Ladies and gentlemen, throughout the duration of this symposium, our discussion have been skillfully guided and facilitated by an individual whose dedication and expertise have greatly contributed to the success of our event. It gives me immense pleasure to inform you that we will be presenting a certificate of appreciation to our esteemed symposium moderator. Now I would like to invite Ms. Bianda to receive a certificate of our gratitude. And to Dr. Misa Hapsari Sakti Titis Penggalih, Sarjana Gizi, Registered Dietitian, Master of Public Health, please come to the stage to give the certificate. Ladies and gentlemen, I extend to you a warm welcome as we approach the final day of our symposium. I have important information to share regarding tomorrow's competition. Tomorrow promises to be an engaging and insightful day as participants will have the opportunity to showcase their research, ideas, and perspective in the competition. As we prepare for tomorrow's competition, I am pleased to announce the room assignment for each category. Kindly take note of the following room assignment. Participants for the scientific competition final category are requested to gather in room 302 Gedung Ismangun. Our diligent event staff and volunteers will be present to assist you with direction and answer any queries you may have. Please ensure that you arrive at your designated room well in advance, allowing for a smooth start to the competition. Thank you for your attention, and I look forward to witnessing the intellectual exchange and collaboration that will unfold during tomorrow's presentation competition. I'm Sabrina Gabriela, and representing the whole crew would like to apologize for the shortcomings during the conference. It is a pleasure for us to be the host of INHESION 2023. Thank you for joining us, and we'll look forward to seeing you at INHESION 2024. Wassalamualaikum warahmatullahi wabarakatuh.
Recording stopped.
Kisah